Good morning. Hi, everyone. Welcome to the Osap Recipient meeting. Of course, we're going live on Zoom, and I wish I could see everyone. I wish we could be here in person, but one more time on Zoom, I hope. And then we're gonna try maybe next year. We'll try next year. Good morning. I want to welcome all of you. So I hope everyone is healthy and safe and ready to have a great virtual meeting over the next 2 days. Days is a pretty full and packed day. I'm excited to hear from all the presenters. We have such I think, a really great group of presenters. And most of you know me, but if you don't, my name is Antoinette Silva Jose, or Tone, also known as Tone. I'm the staff manager at OSAP, and I'm the program manager of several OSAP grants. I'm going to be facilitating today. I have a few items of business first before we get started this morning. I want to see how everyone is doing. So Coop Consulting has prepared what's called a word. They're going to prepare a word cloud for us this morning. So could everyone please, okay, I'm checking to see if you're all paying attention, go on a device or online, and you want to put in this web address, www.menti.com, and enter the code 37401146. And they're going to display this information for you as well. And I want you to type in one word, one or a few words that describe how you're doing this morning. So I'm hoping you can do this. Let's see who's the fastest. No, I'm just kidding, but this is our way to communicate with one another. Tired, I feel you. I don't know if many of you know this, but I'm in Santa Fe today. I'm here in the office today, and it was I had a pretty exhausting, I was just had a long night, had a long day. Long morning feels like I'm not a morning person. Sorry, y'all. Anxious. Oh, wow. And, the pandemic has really put a lot of stress, a lot of, really difficult times. And so I appreciate the fact that you're on this morning. I appreciate the fact that you were out there in the community working on prevention efforts and keeping prevention going strong. Through all of this, I want everybody to keep hope. I want you to reach out, talk to us, call us. We have so much going on. Oh, I see a fantastic. Yes, I love it. I see a ready, relieved. I see indigenous. Awesome. Tired but fantastic. That's a good one. I like that. And hello. There's a hello. Motivated. Awesome. Okay. So I could read these all day, just so you know. I could just keep going, but thank you so much for participating. We're going to gather all of these. I want it saved. Please save me a copy of this. So I want to let us get started, but of course I have to go through a couple of things with you first. You may have already noticed that all attendees have joined the meeting muted. So you will need to use the chat or the Q&A at the bottom of your screen to ask questions, or raise your hand to be unmuted. Only presenters are unmuted and have their cameras on. Presenters, please remain muted when you are not presenting. Please note that attendance is being taken. So we're looking for all of you. So if you know someone's supposed to be on, text them, say, hey, make sure you're online, they're taking attendance. Let me see. The meeting is being recorded. The presentations and recording of this meeting will be available via email and on the New Mexico Prevention website following this meeting. Thank you so much, Coop Consulting, for being able to set that up for us. If you're experiencing technical difficulties during the meeting, please reach out to Jennifer Espinosa Ruiz from, I kept trying not to mess up her name, from Coop Consulting Inc. She's available by phone to help troubleshoot. Okay, that number is, you got your pen and pencil, pen and paper, 269-220-0039. And if this isn't in the chat, I will be concerned. But let me see. I will, oh, there it is. It's at 8:49. So scroll all the way to the top on the chat. Her number is in there, 269-220-0039, or by email as well if you're fast on the computer. I'm going to take everyone through our first presentation, an overview of the OSAP prevention system in New Mexico. And we have a new team member since the last recipient meeting, and I'm happy to introduce her. We also have some new projects across the state as well, and I look forward to telling you more about that. So thank you so much. I appreciate all of you. Again, I can't say thank you enough. Whew, here we go. Let me share my screen and we will get started. Let me pull this up. Oh, here we go. I don't know who set this up, but thank you. Okay, here we go. So OSAP overview of the Office of Substance Abuse Prevention, the grants and the team. Now, I don't know if we can unmute folks, but what I'll do is I'll kind of pause for a minute if we do to say, hey, here's Heather, Jay, Erin, but let me get started. So the so this is a beautiful, beautiful diagram of what is going on with what our funding structure looks like, basically. Thank you so much to Paula for sending this to us and assisting us with this, this beautiful, I don't even know what it's called. Is it called nobody's here to help me, but I'm just gonna go through it, okay? Can you see my screen? You don't see my screen. Let me share my screen so you can see it. My bad, my bad. Okay, here we go. Now, this is basically what everything looks like. So we start the federal government, United States federal government. They give money to Health and Human Services Department for, of course, the nation. And then Substance Abuse Mental Health Services Administration, also referred to as SAMHSA. And then it funnels down to the Mexico state government, and then to the, I think that was my bad. I think it goes to CSAP first, Center for Substance Abuse Prevention, and then the New Mexico state government, and eventually gets to the New Mexico Human Services Department, which that's where we're at. And then Behavioral Health Services Division, specifically Office of Substance Abuse Prevention. And what does that look like on the ground level? That looks like SAPT funding, Substance Abuse Prevention and Treatment Block Grant funding. It also looks like Partnership for Success 2015 grant funding. I know some of you are all aware of that. Also PFS 2020 funding, which is again, Partnership for Success 2020. Let's see. And then we also have the SPIF-RX grant. We also have SOR, State Opioid Response Grant, PDO, and FR-CARA. And I'll go into more detail, so please hold on. So I want to introduce you to our wonderful, awesome, incredible team. I'm biased because I'm on it, but I get to work with them every day, and I know how incredible they are. First, I'm going to start with our wonderful leader, our incredible leader, Karen Chayman. She's the Osap Director, and she is kind of the overall, to me, just the go-to person if you want to know more, if you want to hear more, if you want to, you know, kind of see what's going on. And because sometimes, she's our backup too, because sometimes we tend to have issues, but she's there to help us as well. Then there's me. And we have Heather Burnham. She's a program manager. She's been here for a while. She has a lot of experience, and we do refer to her as our star guru. So she's really great. And we're all trying to, get to that status as well, because we want to be able to assist you any way we can. Myself, Jay, Rebecca, and now we talk about our new person, which is Melissa Heinz. She is our state opioid response program manager, and she is brand new to the staff, but she is kicking it into gear and starting to mingle with everybody, starting to get to know the processes, and she's there. Reach out to her, say hello, ask her questions. She's definitely taken a huge step in learning and trying to hear what is going on. So I'm happy that she's on our team. And of course, I want to mention Rebecca is so incredible that she's also our interim PDO program manager. So if you have any questions on PDO, it's Rebecca as well. And last but not least is Jay Quintana. He is our SINAR coordinator as well as a program manager. And he does so much work with tribal outreach. He is our our savior in the SINAR department, and he kind of gets everything going. He helps us with, you'll hear more. He'll give a presentation to you tomorrow. So please stick around. If you're with the Substance Abuse Prevention and Treatment Block Grant, SAPT funding, you will be working on SINAR with him, as you well know if you've been here many years. And if you're brand new, welcome to OSAP team, OSAP, and yeah, and a lot more, definitely a lot more, Jay. Thank you. And that's kind of why I'm like, I could go on and on and on. But he'll be able to introduce himself later. I don't know if we can unmute and they can kind of chime in for a second, but I don't know, but I'm gonna keep going. So starting his SINAR presentation is starting at 6 a.m. tomorrow. Just kidding. I do want to mention, because we're going to use a lot of acronyms, and I want to make sure you are aware. Well, what does that mean? What does that stand for? So the first one is SAPT, Substance Abuse Prevention Treatment Block Grant. And you'll hear that pretty often if you are on SAPT funding. And if you're not, you may still hear it anyways, because it's a pretty steady funding source that we have for a lot of our providers. So the next one is the PFS 15 or PFS 2015. And sometimes we just, blah, 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 it just rolls off. It's the Partnership for Success 2015 grant. We also have the SPIFRX Strategic Prevention Framework for Prescription Drugs grant. And I hope BCCHC is around. Oh, I'm sorry. Nope. They changed their HEC, Healthy Quality Council. So shout out to Healthy Quality Council under the SPIFRX grant. And the next grant acronym we have for you is PDO. PDO, Prevent Prescription Drug Overdose, Opioid Overdose Related Deaths. Sorry, rushing through it. PDO. And we have a couple more. SOR and SOR 2020. State opioid response grants. Now, those are specific grant funding sources from the federal government to address the opioid crisis. And we have a lot of work going on with those. And it's not only prevention, but we have some stuff across the state. We will solely work on prevention and harm reduction. And so if you ever have questions, we will address it in that way and direct you to the right folks as we need it, or as you may need more information. PFS 2020 is the Partnership for Success 2020 grant, which is a brand new grant to us. And oh, wonderful. Let me finish this last one and then we'll have Jay say hello. We have FR-CARA, which stands for First Responder Comprehensive Addiction and Recovery Act. First Responder Comprehensive Addiction and Recovery Act. And this is, I remember when this came in, there was so much excitement around it. And I think it's a great grant that we have here in the state of New Mexico. And I hope we'll do some future provider highlight in maybe our next recipient meeting about FR-CARA. So I'm hoping that will happen eventually, but I do want to give time to allow Jay to say hello to everyone, because I know he's he's online, so I'll stop for a moment. Go ahead, Jay.
Hi, everybody. Can you hear me? Can everybody hear me?
Yes. Yes,
Okay.
I can hear you.
Good morning, everybody. Just wanted to say hi to everybody and let you all know about tomorrow. I was just joking when I said 6 a.m. or was I? No, but I hope everybody's having a good morning. It's nice to be here with everybody. I really wish that we could have been in person. Just to see everybody smiling and I guess touching base with everybody and how things are going. I really miss that, but I've started to get accustomed to online stuff more, especially Zoom. Starting to get used to it, where I think I'm able to conduct a Zoom meeting. At least I hope I am. But I know everybody has been making adjustments and stuff to get the work done, and I really appreciate everybody. All your work and your effort you put into this work we do here in the state. It's really important. For tomorrow, I just wanted to say for tomorrow, I think I had 8 a.m. listed, but we needed that longer block of time just to go over a lot of the changes that are happening or that have happened at the state level legislatively with the new laws and also with the licensing. And also I kind of really wanted to go over a lot of the providers, and I really wanted to hear from you as far as questions, concerns, comments, anything you had. So if you can maybe possibly come up or think about anything today, bring it to tomorrow's presentation. I kind of wanted to do as much as I could, being that we're not in person. I wanted to do some role playing, even do an example of a merchant education session, if you will, how that goes. So yeah, there'll be more to come tomorrow. At 8 a.m. I think we're scheduled. We'll see if I can hopefully be finished when I said I would. I may take it through lunch, but no, I'm joking. But it's good to see everybody. Good morning. Thanks, Tom.
Thank you, Jay. It's always great to hear from staff. I don't know if you can turn on your camera, but it'd be great for us to wave and folks can see you. And
I was trying. I see. I don't know if I have the option to turn my camera on. Also, I know they turned my mic on.
You should.
Oh yeah.
It'd be good for everybody to see you. Okay, I would also like to invite, there you are, there's Jay, Karen and Rebecca and Melissa to say hello. I just want folks, because I'm an in-person person, or I would like to see people. So if we can show folks online, it would be great. Could we start with, let's see, Karen, are you available? There she is.
Yes,
always
I am.
ready. Always ready. Thank you, Karen.
Good morning, everyone. It's really good to at least hear you. It's a little hard to see you, but we're really glad to be able to be with you all again and be able to share some information and exciting news and continue all the great work that we've been doing with you for so long. And I'm also very glad to have Tone be able to facilitate this meeting. So take it away, Tone.
Thank you, Karen. Next, may we please have Melissa. Hi, Melissa. Say hello.
Good morning, everybody. I just figured out, but I think we just switched, right? I was trying so hard to figure out how to see everyone, but in webinar mode, we can't. Now you've invited us and now we can.
Yeah, webinar mode, they can see us, but we can't see them. But they're out there.
We know you're out there. Everyone, I'd thrown it in chat. I've been with the team since, I guess it was mid-May, and I still feel like a newbie, but Karen is assuring me that my newbie status is about to wear off, and it's really great to be back in New Mexico, and it's just a particular honor to work with this team and all of y'all. And we'll meet in person soon, just not quite yet. So, but thank you. I manage the state opioid response prevention grant. Great to be here this morning.
And can I just say that we worked with Melissa 5-6 years ago when she was still in New Mexico and worked at the Department of Health. So Melissa is not actually new to us. And so we're really happy to have her on board, and all her wonderful experience and expertise is just going to expand what OSAP can do. So welcome, Melissa.
Thank you.
Thank you so much. All right. Hey, Rebecca.
Good morning, everyone. It's nice to be with you all virtually. It is a little strange not seeing people, but it's great to be with you. And thank you so much for all the work that you do and all your patience with us too. And I really do appreciate all of you. Thank you.
Thank you so much, Rebecca. I know we mentioned Heather, but I know she'll be presenting a little bit later, so she'll do in her own introduction then at that time. So thank you, all of you, my awesome coworkers, my awesome, wonderful group I get to work with. So thank you. All right, I'm heading back to the slide, heading back to the PowerPoint. So thanks again. We'll talk more. And can you see okay, there you can. Now you can. All righty, moving on. I want to start diving into the SAPT, Substance Abuse Prevention and Treatment Block Grant. This grant works on reducing underage drinking, reducing adult binge drinking, reducing adult DWI, reducing prescription opioid and illicit opioid misuse among youth and adults. It also focuses on SINAR, as mentioned earlier. And a lot of folks ask, what is SINAR? What, is it an acronym? What does it mean? What does it stand for? And Jay will do an entire presentation about this, but if you're not SAPT funded, you won't technically be able to hear all of it. So SINAR is named after a person. He was a representative that went to the legislature to change the law and make sure we have these laws that say you cannot sell to anyone under the age under the law. And recently it changed. It went from 18 to 21. So no one under the age of 21 should be able to purchase tobacco. And again, this is around youth tobacco use prevention. And part of the SINAR amendment, the SINAR work that is being done across the state for providers is we do a portion of the work, and the work is called merchant education. We refer to it as merchant education. The providers go out, they visit a store, a grocery store, maybe a gas station, anywhere that sells tobacco, e-cigarette places, sometimes they're small, and they remind them of the federal law, the state law, and kind of just do an education. It's kind of like, hey, buddy, I want to tell you about something because I want you to be aware. I want to increase your awareness. So there's a whole purpose around why SINAR is so important, why we do it. So I like it too. The folks that are contacts for the OSAP team that focus on SAPT block grant is Karen, me, Tone, Heather, and Jay. PFS 2015, Partnership for Success 2015, works to address underage drinking among persons aged 12 to 20. It also focuses on prescription drug misuse and abuse among persons aged 12 to 25. Contacts are Karen, Heather, and myself. The Strategic Prevention Framework for Prescription Drugs, SPIF-RX. You'll kind of hear that if you're hear that word, that acronym a lot. I like it, SPIF-RX. This grant is focused to raise awareness about the dangers of sharing medications. It also works with the pharmaceutical and medical communities on the risk of overprescribing to young adults. I really enjoy this part because I've been able to work with the Health Equity Council and talk with them and talk about their progress in, and also their challenges, because working with the medical communities is, it was a challenge as soon as COVID hit, because a lot of their medical folks, their attention went to, obviously, to COVID, right? And now it's really trying to rebuild those relationships, kind of see, is it a possibility for them to talk about academic detailing, to talk about all these different strategies that focus on prescription drugs. How do we begin to encourage them to build awareness, but also I think there's a lot of things happening around the state as well to encourage providers not to overprescribe. So I think it's being aware. I mean, the awareness is being increased. Also, this focuses on the prescription drug monitoring program, PDMP, and sometimes you may hear it called PMP. Contacts are Karen and me. Now, this is a slide about overdose prevention. Now, we have many grants that focus on overdose prevention. Not many, but we do have grants that focus on overdose prevention. Training in preventing and responding to opioid overdose. All right, raise your hand. How many have heard of Narcan? How many of y'all have heard of Narcan? I sure hope you have heard of Narcan. Thank you, Jesse. I can see your hand. But you can put your hands down, but Narcan is out there in our communities. And at the beginning, there was a challenge to have folks kind of make it more aware, have pharmacies make it more aware. And now we're working to build those, drop those barriers down to make sure Narcan is readily available in our communities. And I think we have done a tremendous job here at OSAP to get Narcan out to our communities and make it available. So if Bernie is on, shout out to Bernie. If Jay is on, shout out to Jay. Those those are the guys I know. I think Phil is always, I'm sure there's many of you, right? Many of you out there, but of course, those are the ones I know right off the top of my head. And then there's also media efforts to support and reduce stigma, because we want to work with, how do we get to everybody? How do we do media spots? How do we do billboards? How do we work with specific communities? So I do want to emphasize, we have a Native American opioid overdose prevention media campaign. And I have the sticker on my phone. I love this sticker. I love the design. If you can see, there's a medicine wheel and there's an eagle feather. And this campaign was trying to reach the Native American population in the state of New Mexico. And there's different campaigns starting now. And so there's much happening. Let's see. Okay, here are the funding sources. I hope you remember STR, SOR, SOR 2020, PDO, and FR CARA. And if you want to talk later, I'll tell you the distinction between SOR and SOR 2020. Results. Let's talk about some results. In 2017 to 2021, over 46,600 nasal Narcan kits were distributed. That's a lot. That's a lot. I just have to say that's a lot. 33,000 trained OSAP providers and community partners. 880 reported reversals using BHSD funded Narcan. And we're always working to gather more data. We want to gather as much data as we possibly can about those reversals that are related to all the Narcan that is being handed out in the communities. Sorry, trying to clear my throat. PDO. The purpose is to reduce the number of prescription drug opioid overdose related deaths for individuals 18 years of age and older, serving Bernalillo, Doña Ana, Rio Arriba, and Santa Fe counties. The contacts here are Karen and Rebecca. I know I don't want to read too much to you, so I'm gonna kind of cut my reading back a little bit. But if you are only listening and just hearing what I'm saying, I'll finish reading it for you. opioid overdose recognition and response trainings, Narcan purchase and distribution, creation and support of Narcan distribution networks. And to me, that is like the biggest walk away for PDO, is that they're creating and trying to have those Narcan distribution networks, which I think is very valuable within our communities when we talk about sustainability as we go forward. There's some questions in the chat, and I'll Concha, I got your question. I'll forward it to Rebecca to tell you who's there at Rio Reba. FR CARA, First Responder Comprehensive Addiction and Recovery Act. This is training for professional and volunteer first responders throughout the state to reduce overdose deaths and improve outcomes for survivors. Again, reduce overdose deaths and improve outcomes for survivors. Technical assistance for creation of overdose survivor outreach programs, development and support for fire departments, overdose survivor outreach programs in Las Cruces and Santa Fe. Purchase of Narcan for first responders and overdose survivor programs. I want to say, I believe they're hopefully going to be adding another fire department, if I'm not mistaken, to this grant. So we'll see as things get progress. OSAP context for FR CARA, Karen Chayman and Rebecca Newbeck. STR, state targeted response to the opioid crisis extension. Opioid overdose related deaths through the provision of prevention and harm reduction activities, tribal opioid outreach, contacts here at OSAP, Karen, Rebecca, and Jay. SOR, so SOR, we have PACS Good Behavior Game, Indigenous PACS, Overdose Prevention, Education and Harm Reduction, and a Dose of Reality campaign. If you haven't visited a Dose of Reality website, please do, please do. All right, I'm gonna fly through these. Opioid Response Grant, SOR. I do want to mention this is different. Tribal Lead Program is pre-arrest diversion for substance use disorders. That falls under the SOR grant. I want to mention that we here at OSAP work with tribal nations across the state of New Mexico on primary prevention, and the contacts are Karen, myself, and Jay. Quick spot on PACS Good Behavior Game. If you don't know what it is, it's an evidence-based program. It's an evidence-based program that focuses on self-regulation, and it's typically focused with kindergarten through third grade age students in the school. So majority of the time, PACS Good Behavior Game is implemented in the school. And as you can see, we have 18 school districts, and we have about, I want to say at least 7 or more tribal communities that are participating with PACS Good Behavior Game. There's some successes at the bottom of this page. And of course, thank you. We're here to give you more information, and we'll have more time to discuss all of this. You will get a copy of these slides, everybody. And we'll have some time later to talk more about how things are going. I want to mention that our next speaker is also helping to make a difference by offering prevention specialists across New Mexico excellent top-notch training and workforce development opportunities. Paula Feathers is the New Mexico Alcohol, Tobacco, and Other Drug Abuse Prevention Workforce Training System Director. Nearly everyone working in prevention knows Paula, so we asked her to share something about herself that you may not know. Paula is Pawnee and Cherokee, but was raised in Zuni. Paula loves going on road trips and eating at local restaurants. Yes. Paula is here today to tell us more about the training system. Over to you, Paula.
Good morning. Thank you, Tone. Appreciate it. Okay, let's see here. I'm going to share my screen. I'll see how this goes. Sorry about that. Let's see, share. Okay. Can everyone see that? If somebody could just give me a thumbs up, I'd appreciate it.
Yes.
Okay, great. Okay. So as Tone said, my name is Paula Feathers, and I have had the blessing of working with the training system now for about 10 years. I have been doing prevention for about 19 years and absolutely love it. It's been my calling. And so being able to work with every single one of you in the prevention system is the greatest gift that I could have asked for. Before we get started, to tailor the presentation a little bit, I do have a poll because I want to see how many of you have not used the training system before. So I believe, Jennifer, if you could please put up the poll, that would be fantastic. So if all of you out there could please just answer the question, have you taken a training with the prevention workforce training system before? That would be really helpful to me. Fantastic. Thank you all so much for answering that question. It's really exciting to see that we have a bunch of people online who have not taken the training. That might be because you're new to the system, or it might be because you're a director and you haven't had time, or it's not necessarily in your scope of work. But there's going to be some information in this presentation for both people who have taken, who have used the training system, and for those who have not. So let's go ahead and move on. Again, thank you for answering that question. Whoops. Okay. Got to use this. Okay. So what is the training system? This is for those of you who answered that you have not used the training system before, or you are new. And if you are new, welcome to OSAP. You'll find that this funding source, you work with some really incredible people, and that there's all kinds of resources available to help you be successful. The training system is one of them, but I would also highly encourage you. One of the beautiful things that I get to witness is that when we do have trainings, the people, the connections that are made, and how much people are willing to help each other out. Don't be shy to ask other programs for their guidance and their assistance, because there's some people who have been doing this type of prevention programming for a really long time, and they're incredibly gracious with their time. So if you're not used to asking for help, get used to it, because the people that your colleagues are phenomenal. So keep that in mind also if you feel overwhelmed as we're going through the meeting today and you're new to the grant. The training system, the whole goal is to elevate and strengthen preventionists, specifically substance use preventionists within the state of New Mexico. OSAP has been funding a training system, I would say probably for 20 years. They've invested, they see that having a workforce who has the opportunity to have trainings in a bunch of different areas is incredibly helpful and helps provide effective services within everyone's community. And we work really hard to meet the needs of all of the different people that OSAP funds. And let's see here, there's some different language that I'll use. And if at any time you have a question, don't hesitate to let me know. I'm not really, I can't see the chat. And so if a question comes up, I'll see if I can notice it. But one of the bullets on here, it says that all of the training that our system provides is approved for Form C. If you're not familiar with Form C is everyone who's funded by OSAP is required to take a certain amount of training. And the way that you document this training is through writing it on Form C. And so there's been questions before about some of our topics, like let's say that you're funded to work on opioids, but there's other trainings like alcohol or tobacco that you want to take, and you are afraid that it might not be a good fit because of your scope of work, because you're focused on opioids. All the training that we offered is approved for every provider. So anything that we're offering, OSAP has already provided, and regardless of what your priority area is, you can take training in all of the different things that we offer, because we do want to work on getting people certified in the prevention specialist credential, and also just to elevate your knowledge when it comes to effective evidence-based prevention. And then there is all of our training is, we are also an approved provider for the New Mexico Credentialing Board for Behavioral Health Professionals. They are the agency that does the prevention certification. And so all of our training is approved by them and can count towards them. We are not a part of that agency. We are just an approved provider. So any questions regarding credentialing, we could help you with those things, but we can't, but they're a separate entity. And so if you ever have questions about certification, you can ask us, but it's also good to contact the board directly. And then the other thing is that all of our trainings are developed in collaboration with OSAP. And so we offer our training is to meet the needs of everyone who is funded by OSAP. And so there's some contracted training that people are required to take, like ethics, and we've changed from SAPS to SUPS, which is the Substance Use Prevention Specialist training. We offer those, we'll offer ethics at least twice a year, and then we offer the SUPS at least twice a year. And then we offer drug specific training because that's one of the hardest trainings to get when it comes to getting your credential. So we do our best to have one of those every quarter. We weren't able to have a drug specific training this first quarter, but we are going to make it up in the second quarter and have a couple of them that you'll be able to take. And then we also provide trainings that help you implement your scope of work with different strategies like responsible beverage service or working with law enforcement, all of those different things. So our training system is designed to help you be successful. And another way that we work to be successful is if you let us know at any time that you have training needs, that really helps a lot. So for example, one of the programs reached out to us in July, I think, and said that they just got the grant and they're having to build a coalition. And so we're going to work really hard to make sure that we have a coalition training coming up the second quarter. Most of the time when people have requested trainings, we've been able to provide them. And so don't hesitate to reach out to me or the rest of my team, who I will introduce you to at the end of this presentation if you have training requests. Sorry about that. So who can use the training system? This is an important area, especially for those of you who might be new to the contract, that each funding, every program, OSAP program, is eligible to have 5 to 7 people who can attend the trainings for free. These should be people who are working with you as part of your core team. You'll see that language in your contract to help the grant be successful in your community. And so it can be anybody of your choosing, 5 to 7 people. And the core team, so the thing is that whoever is your local program manager, your coordinator, or your director, you're responsible for getting that list of 5 to 7 people to your program manager, your OSAP program manager, before the end of the month. The new core team lists take effect the first of every single month. And so as long as you get your core team list to OSAP, your program manager at OSAP, before the first of the month, that gets revised on a monthly basis. So also, if you need to change or update your core team, all of that is the same. Make sure any changes that need to happen by the first of the month. And then we personally at the training system do not change the core team list at all. That's OSAP's responsibility. Whatever list they give to us is what we put up on our website. And so really make sure that you work with your program manager when it comes to your core team list. If you ask us directly, we're not able to change the core team list on our end. And I think, and the other people who are able to use the training system are other preventionists in the state, but they use the training, each training has a fee. Okay, so I hope that helps. Let's see, let's go to the next one. Okay. How do I take a training? And this is the website where you can find everything that you need to take a training. And I'm going to show you the website. So I hope that this transitions smoothly. We'll see how it works. There's this. There we go. Okay. Okay, is that one showing up? When I jump pages like that, does that the page still show? Okay, thank you. Okay, here is our website. And this is the homepage, and this is where you can find everything that you need to take a training. I would highly encourage you to subscribe to our listserv. This is where we announce when our new training schedules come out, or if we have room in existing trainings. We're really conscious about not sending out a ton of emails on the listserv. We keep that really minimal. And so if you're not a member of the listserv, I would encourage you to sign up here, subscribe, give us your email, and you'll start receiving training announcements when they go out. Also on this page, you can download the brochure if you want to see what the quarter trainings are, or you would like a hard copy. You can download our flyer here. And then you can also click to look at the current trainings that we're going to offer, and we'll check that out in a minute. And then there's our policies. Our training system runs so effectively because we've established and we maintain policies. And it just creates a really good training system across the board for everybody. And so it's really important to be familiar with the policies. So for example, when to cancel, or if you need to register, how many days you have to register, how many days you need to cancel ahead of time, what you need to do in order to get your continuing education hours. All of that information can be found on the website under the policies. And then this is another area that I wanted to point out to you at the bottom of the homepage. This is these trainings these are actually trainings. So you can click on these. There's Excel, there's fiscal management, and there's using the strategic prevention framework. And we also have a naloxone training. All of these trainings are available online anytime. The only thing is you can't get continuing education hours for them because in order to do that, the credentialing board requires that online training has a trainer, like a facilitator who's monitoring your work. These are completely self-paced, and they're just in case you want to increase your skill level in any of these areas. And the Excel is amazing. If you haven't had the opportunity to take a really good Excel training, this is a really good place to go to learn how to use for data collection and for graphing and things like that. And these trainings right here are open to everybody. You don't have to be on the core team list. You just register and you can take the course. So if there's other people in your community who you would like to say to take the naloxone training, they're more than welcome to do that. And then here, I also want to point out is that we do 2 levels of evaluation with our training system. We work really hard to provide effective training, and the way we do that is through evaluation. And so we offer, we have a post evaluation. As soon as the training is over, you'll complete an evaluation, and that's part of completing the entire training. But then there's also a follow-up evaluation, which is like a quarterly evaluation. And this is where you give us the opportunity to give us feedback about how you've been able to use the training, if you use the training materials. And this is crucial to us. It really helps us grow and get better as a system. We use that information. We don't just collect it and have it sit somewhere. We review it really thoroughly, and we use it to make improvements to our system. And so not only do we is the information useful, but you get the chance to win a $50 gift certificate or a $50 like credit card or gift card. And there's 3 people that win those every quarter. And right here, you see that our most recent winners of the $50 gift cards were Joanna Wells, Megan Smith, and Michelle Ricon. So again, just encouraging you to take the quarterly evaluation because it really helps us. And if you want to register for a training, you can click on the training registration part, and then it has a list of our training here. And so, for example, here is ethics for the prevention professional. It gives you the date, gives you the end times, the price if you're not a core team member, and then you just click to register, and it'll take you through the process. Okay, let me see if there's anything in the chat. Okay, and then, so I'm going to go back to the presentation. I just wanted to show you the website. And we do have a couple of new features for those of you who have used the website before. I mentioned that we had some stuff for everybody, not just the newbies. Okay, for those that, so this is both for people who are new as well as for those who have used the training system. My amazing web team have added a section to our registration page that we're hoping will make it easy for everyone. So from this point forward, whenever you register for a training, you will create a login, a username, and a password. And you'll also use this for your online trainings because we offer both. Currently, we offer live, like on Zoom or Adobe Connect. So those are what we consider live trainings while we're going through the pandemic. And then as we get out of the pandemic, we'll also offer in-person trainings. So we offer those as well as online training where you have a set amount of time to take a training. So like, for example, the ethics one that we just looked at is considered an online training, and you would have 10 days to complete those 6 hours. And so when you register, either way, you'll create your username and your password. And by using a new system like this, it enables you to manually cancel your own registration. So you don't need to send an email to us anymore. You can go into your portal and cancel a registration as long as it's within the time frame that the policies state. And this is just an example of that. So let's say that you registered for a training and that you needed to cancel it. You could hit the cancel registration and you would be able to do that without sending an email. Okay, let me see. There's a few chats. Okay. All right. And I think that's it. This is the Kamama Consulting team. We have Noah Salvatore. Noah is our amazing website person. He is responsible for creating our beautiful webpage and updating it and doing all of the online trainings. And a lot of you might know Contretta and Warrior. She's also one of our team members who provides the online training support when we do live web-based trainings. If you have any questions about logistics, if you have questions about certificates, if you have questions about registration and things like that, you're more than welcome to contact Contretta. And we have Shannon D. She also helps with our evaluation as well as our website. Noah and Shannon just do an amazing job on the website, and I'm so grateful to them. They help our system work really well, and they put a lot of time and effort into it. And then Contretta too just really cares about all of the participants that she works with. And she really does a great job of making the online training experience as glitch-free as humanly possible. And I think that's it. And then again, I'm Paula. If you have any questions about trainings or would like to request trainings in the future, don't hesitate to contact me. I'm open for that conversation. And I think that's all I have, Tone.
Thank you so much, Paula. I just want to say we're here at OSAP, we're incredibly grateful for all the work you're doing. And it's been a rough year, and you have moved everything online and are just kind of excelling at an exceptional rate. And we're so grateful to have you run our training system. And so thank you so much. Thank you for all that you do, Paula. I appreciate you so much. Thank you. So I want to move on. Our next presenter is from the Health Equity Council in Bernalillo County. They're the holder of a SPIF-RX grant, and they focus on decreasing the misuse of prescription opioids by engaging medical communities and pharmacies, youth and parents, and incorporating data from the prescription drug monitoring program into assessment and evaluation activities. Christine Mintz is the health promotion specialist at the Health Equity Council. She will be presenting along with Ashley Simmons-Rodolph, research scientist at the Pacific Institute for Research and Evaluation, also known as HIRE, another acronym. Something you may not know about Christine is she can make over 20 different types of handmade pasta. Oh my gosh. Ashley, her co-presenter, had a previous career as a stand-up comic. It only lasted one night. Christine and Ashley I will turn it over to you. Thank you so much. Folks are already sending you requested dinner invites, Christine.
Perfect. Hi, thank you so much, Tone. Good morning, everybody. I hope everyone can see me and hear me.
Yes, we can hear
Okay,
you.
perfect. And I'm going to share my screen. Can everyone see that all right?
Yes, we can.
Great, thank you. And thanks again, Tone, for that introduction. Again, my name is Christine. I'm from the Health Equity Council, and I will be presenting about our work on SPIF-RX. And I'm so thankful to you, Tone, for the acronym explanation, because when I remember when I first started, I think my first recipient meeting, I heard someone say an entire sentence of just acronyms and like with an and. And I was so confused. So if at any point I use one, please ask us at the end, ask me in the chat, because I've tried to avoid that as much as possible. So let's get started. So who are we? First, a brief explainer. For those of you who have been doing this work for quite a while, you might know us as the Bernalillo County Community Health Council. And that's been our name for about the last 10 years, ever since we became a nonprofit and kind of started doing this work in Bernalillo County. But we recently underwent a name change. We pulled a Prince, and we've become the Health Equity Council just in the last few months. And so you might see BCCHC or HEC referring to us, but we're the same entity. So just to avoid any confusion, Bernalillo County Community Health Council, I think, is the test of new employees to see if you can even say that. It's a mouthful. And we also wanted the new name to reflect some of the other work we do around equity. So what do we do in terms of the work around opioid prevention? So about in 2012, we convened several different opioid summits in Bernalillo County. And this involved policymakers, providers, leaders, community leaders, teachers, anyone who was interested in this work around what are we going to do about opioids, basically. And these led to the formation of something called the Opioid Accountability Initiative. And this merely refers to the formation of a few different community groups with different areas of focus. So a prevention initiative, a prevention coalition, a harm reduction group, a treatment focus group, and then a law enforcement group. And so these were kind of the four main pillar areas that came out of these opioid summits. And then, so just to establish that there was some really good infrastructure already, some good work going on in Bernalillo County around this issue, even before the SPIF-RX grant was awarded in 2016. So at the Health Equity Council, I'm lucky enough to also work with some colleagues who work on some of the other initiatives that Tone mentioned, so we can kind of brainstorm about how to work together and feed two birds with one stone, as it were. And so those are prescription drug overdose, like Tone mentioned, Narcan distribution, anti-stigma education. I think Larry is on the call today. He's a colleague of mine, which is really exciting, designing stigma education around this issue, especially for different populations, because we all know that stigma for law enforcement is pretty different than stigma for, let's say, providers, but it still exists. And then ABC Prevent is also another initiative at the Health Equity Council, and that focuses on youth and young adult opioid and alcohol prevention. So just to say, we've got a lot of irons in the fire around this issue, which is actually really helpful because we can coordinate, we can compare notes, we can brainstorm with each other. And then overall, just as an organization, you name it, we probably do it. We focus a lot on social determinants of health, equity, education around public health, violence prevention. We do policy research for the city and the county. We're trying to get more into environmental health. And then overall health accessibility, whether that's access to services, access to our elected officials, access to basic needs. All right, so Tone gave a great introduction, but I just wanted to reiterate that what is SPIF-RX? It's preventing, the overall goal of SPIF-RX is to prevent the use and misuse of prescription opioids. And I've underlined prescription because we really do, we're focusing on prescriptions. And not to say that we ignore things like heroin or illicit opioids, because we know they greatly overlap. But for the purposes of our work, we do want to specifically focus on prescription opioids in our community. And I like to break the work down by three broad categories, and there's different strategies. Some of you might recognize our SMART objective kind of menu indicators at the bottom. Some of you have them. I've placed asterisks by ones that might be unique to our grant because we were lucky enough to be able to test out some pilot strategies. So I like to break it down by community, providers, and then media, which is interesting because that can kind of serve as a conduit between the two. But oftentimes media is only a one-way street. And so, some of our media, be it social media, is trying to make it a two-way street. And so as far as community, our focuses are on parents and guardians and community access to opioids. So things like diversion through sharing of medications, locking up, safe storage, parents speaking to their children about the dangers of opioids. Through providers, our strategies focus on provider education through individual one-on-one training and group education, and I'll get to that later. The development of a provider guide, as well as pharmacy outreach. And as far as media goes, we really wanted to focus on a targeted social media campaign, which I'll get into more in a little bit, as well as one of our pilot strategies is called Bootcamp Translation. And the easiest way to explain that is it's a form of community-based participatory research or a series of structured focus groups with very, very specific goals around creating media around opioid prevention. And how do we measure it? I know the PIRE folks are on this call and they will be doing 2 different data presentations today. I won't get too much into it, but overall, we want to reduce the use and misuse in BurnCo. Our assessment tools are the community survey and the YRS, as well as some other provider indicators like the prescription drug monitoring program, as Tone mentioned. We have a provider survey that we've done. In terms of some indicators, the way that we measure in the community is self-reported locking up, self-reported sharing. We measure our providers by looking at things like morphine milligram equivalents, and I'm going to talk a little bit more about that in a second. Overlapping prescription medications, so we know some of the dangerous ones are overlapping opioids and benzodiazepines. Provider education, and that refers to when we ask community, when you were prescribed an opioid, did your provider talk to you about the risks? That's one way we can measure how these conversations are going with providers. And as far as media, media can be really hard to measure. So we look at overall awareness of harm in the community, safe storage in the community, things like that. And then we can look at social media metrics, but again, that's a little tricky to actually measure, some sort of behavioral change. But we'll go more into that in a little bit. So here's one of the indicators I wanted to highlight. Again, there will be more and much better data presentations later in the day, but one of the indicators we look at with provider education is around high dose opioid prescriptions. So ideally, we don't want people on high dose opioid prescriptions. And this is a number set by the CDC, which is 90 morphine milligram equivalents a day. And I'll do a little explainer on that in a second. But that's a lot. And that number is kind of set subjectively by the CDC based on some research. I've actually heard that they want to maybe drop that down to 50 based on the way that some of the studies have gone. But the thing I want to highlight here is that we are moving in the right direction. So as you see on the bottom, these are number of people in New Mexico and then Bernalillo County on the bottom in blue with these high dose prescriptions. And then you can see it goes all the way, I believe, to the second quarter in 2020, and we get these numbers from the PDMP. And so one thing I wanted to say here, if you're not familiar with morphine milligram equivalents, when you're doing provider education, and I'll get into that too in a little bit, it's actually really important that we as preventionists know what this means so that we can talk effectively to providers about this. And so I'll use an example. One of the most common opioids we all might have gone home with after wisdom teeth or a broken leg or an injury would be Vicodin. And oftentimes you'll see Vicodin 5/300. And so that would refer to 5 milligrams of hydrocodone, the opioid component, and 300 milligrams of acetaminophen or Tylenol. And in fact, Vicodin comes in 5, 7.5, and 10. And that first number is the amount of opioid. And the reason I picked hydrocodone as a good example is because the morphine milligram equivalent conversion factor is 1. So it's just 1-to-1. So if you take 1 5/300 hydrocodone in a day, you've had 5 morphine milligram equivalents that day. Well, if we think in the context of how these are prescribed, Vicodin is usually given 5/300 every 4 to 6 hours, 1 to 2 as needed. So conceivably, you could be taking it appropriately you could take a 5 milligram Vicodin every 6 hours, let's say 4 times in a 24-hour period, and you've had 20 morphine milligram equivalents. Make sense? And in fact, there's some really great handouts, like the CDC has a handout even called Calculating Total Daily Dose of Opioids for Safer Dosage. And that's something every provider needs to know about. They need to be able to calculate it quickly. And this is something we as preventionists, when we work with the provider community, we need to be able to provide it to them, and we need to be able to speak the language as well. Because if you were to switch to another medication, even let's say a medication for treatment like methadone, it would be different, right? There's a different conversion factor. So to be able to switch between those, calculate quickly the total morphine milligram equivalent is really, really important. And as far as risk goes, the VA did a study between 2014, I believe 2004 and 2009. And they looked at everybody who had gone home with high dose morphine milligram equivalents. And so it was basically the average was 98 versus everyone who had gone home with about 48 morphine milligram equivalents. And that 98 number, those were the people who ended up overdosing. So the danger is almost basically, if you look at between about 50 a day and 90 a day, that is where the overdose risk goes exponentially up, and even between 20 and 50. So if you're on 20 morphine milligram equivalents a day versus 50, it's twice the overdose risk. So we might think that these numbers, like this is the prescriber's responsibility, I don't need to worry about it, but I think we all do. I think we all need to be aware. We need to know what people are taking. We need to know how to talk about this. All right, so one of the other indicators I wanted to highlight also around provider education is when the providers educate people around risks. And so this is an interesting indicator. So the blue is providers, so that would be whoever's prescribing medication, and the red is pharmacy staff. So ideally, we want both these numbers to be at 100%, right? You received an opioid, your doctor told you about it, they told you the risks, they told you about safe storage, they told you about disposal, you went and you filled it, and the pharmacist did it all over again, right? And gave you Narcan. And so here is where we actually see where we could fill this gap. There's a lot of work here we can do, especially when we ask the providers, right? Because these are indicators of the community. The community saying, I only heard my provider tell me about 57% of the time that opioids, were risky. When you ask the provider the same question, it's over 90. So the provider is self-reporting, I'm telling the community 90% of the time when I prescribe an opioid. So there's a disconnect there, right? Between what the community is hearing and what the provider is saying. And not to say anyone's, misrepresenting, but whether it's the communication gap, whether it's in the discharge paperwork and the person never read it. There's real work to be done to bring those numbers closer together and get it above 100. And interestingly, I actually thought that pharmacy staff might be higher, but in this case, it's not. So it's interesting to look at these indicators and see that we really have some room to get in there and do some work as preventionists. Here's another indicator I want to highlight. This is past 30-day, this is from the YRS, and it's youth past 30-day use. And the reason the indicator looks different in 2019 is because the question actually changed. So prior to in 2017 and previous, the question was, and you can see here at the bottom, past 30-day use to get high. That's the way the question was phrased. And then in 2019, we changed the question to past 30-day use for any reason other than the doctor prescribed it to you, basically. So did you use it for a reason that was not prescribed to you? And that's really key, right? Because, and we could talk about this indicator for another half an hour. I think it's really fascinating. Because one, the indicator, so these percentages, it's basically anytime a kid answered yes. So before 2017, I've used a painkiller in the last 30 days to get high. And then when they answered in 2019, it was for any other reason not prescribed. So that's really interesting because they could have said, I've used it 10 times in the past 30 days, but these are indicators of any time there was a yes response. So percentage of yes responses in youth. And I think it's really interesting because we've had this conversation a lot in the community that used to get high is stigmatizing. It means different things. It can be really subjective, and even use for any other reason can be really subjective. But I think it points to the fact that there are a lot of reasons that someone might use a prescription medication not as prescribed to them. And it doesn't mean they are doing it with ill intent or intentionally to quote unquote get high. But I think it's something we can really explore in the community, and we can really highlight different aspects of this question, especially when we get to messaging with youth, right? We're going to get to that in a little bit. And please, I'm not able to see the chat now, but I will look at it at the end. Ashley, yell out if there's anything major.
Yep.
And great. All right. So what do you think of when you think of primary prevention? I'm just curious, and maybe throw them in the chat because I'd love to see it later. Like, what's the first thing that comes to mind for anybody? Especially those of you who are new, I would just be fascinated to know what pops into your mind.
Christine, we've got don't use drugs.
Yep.
Strategies used before a diagnosis, reducing poverty, preventing any problem before the problem occurs.
Great. Thank you, everybody. And actually, I'm so glad that Paula got to speak right before me, because taking it was the SAPST training when I took it, but the SEPS training really helped me nail this down, because I think when you think about primary, secondary, tertiary prevention, and then you think about universal, selected, and indicated prevention, your brain can melt a little bit, especially if you're going through examples for the certified prevention specialist exam. And that's not to say that once you get it, but it can be a little bit confusing when you're thinking about, okay, well, what am I doing? Am I screening here? Am I targeting a demographic group I know is at higher risk? And usually, as a side note, the best way that was ever explained about universal, selected, and indicated was universal, I'm doing a campaign for everybody. Selected, I'm targeting a group of people who have risk factors through no fault of their own. That would be like maybe a familial risk, but they've not engaged in any risky sort of behavior. And then if I'm doing indicated, that's where maybe a problematic behavior has already occurred. Maybe they've already mixed medication and alcohol, and we're going to do a prevention education training about not mixing medication, things like that. But usually when I think of this, or when I hear examples in the community, the first thing that comes to mind is the river example, or the upstream, downstream. Right, and we hear the word upstream, downstream a lot in prevention work, right? Because we often have we're trying to put out the fire and the discussion, or now I'm mixing metaphors, but we're trying to save somebody from drowning, and the prevention community is going, well, let's keep them from falling in the water in the first place, right? Because a lot of times, I think people in the community, their mind goes directly to treatment. We need more money for treatment. We need more treatment centers. Absolutely couldn't agree more, but let's prevent people from needing that in the first place. And I think a lot of people, it's hard to wrap their brains around that until they really start to try to do this type of work. The actual example I like to use when I'm talking about primary prevention is from Back to the Future. So really, with prevention, it's really hard because we're trying to do education, right? We're trying to do education that might not be needed for someone for 20 years. Let's say we're talking to a community group and they're kind of nodding and they receive our messaging, but they might not, let's say they break their leg in 20 years. And then do they recall what we told them around opioids? Do they remember that they're supposed to ask their doctor about, is this safe for me? What am I supposed to do with the extra medication? A lot of times it can feel like we are trying to go back in time and tell everybody what we wish we knew 20 now, And one of the examples I can think of the most is, I played sports in college, and this was, now I'm going to, age myself, but this was about 15, 20 years ago. And we all had prescriptions for opioids, everyone on the team. No one ever talked to us about it. There were numerous instances where people would mix alcohol and opioids. No one ever spoke to us about the possible risks, the consequences. And I was talking about this with a relative the other day, and they were like, holy crap, like no one ever even told you, right? And at that time, we didn't know. We didn't know what we know now. And I'm sure providers would say the same thing. And so this is the challenge of prevention, is how do we figure out creative ways to have our messages resonate with the hopes that that information will be recalled when people need it. And for some, I think even the bigger challenge is we know we have groups that have risk factors. We know we have identifiable demographic groups that might be more inclined to misuse opioids. But what about the rest of the population who thinks this is never going to be an issue for me ever? So how do we get them to listen to us just in case? And that's really challenging. And so this, I want to give everyone credit, because this is not easy, right? It's not easy to do this work. It's actually quite challenging. And another thing, when we are trying to go back in time or trying to get our messages to resonate, and I think actually, Paula, I stole this from one of the Kamama trainings. So again, another shout out to you. But we have to consider our messaging in context of where the person is, right? Or where the community is. And I would challenge you all right now, just this morning, sitting in this meeting, to try to rank yourself on like a 0 to 10 in each of these sectors. How are you feeling? I'll give everyone 30 seconds to just do this exercise in your own head. It can be a little striking, right, when you do your own self-assessment, because these are hard. We all struggle with these areas. We can be completely functional working adults and really be struggling with some of these dimensions. And I say that just to highlight that all of these are going to impact how prevention works. Because if someone's not safe in their home, they don't want to hear me tell them to eat better food and don't do the thing that makes them feel better, right? Or if someone doesn't have adequate support for emotional and physical pain, and the only relief they get is with their prescription opioids, and I'm going to come along and tell them you should taper down by 20% a week, and then you should stop taking this. If they have no alternative for relief, my message is not going to get through. And so that's just to say that each of these things is extremely important. Each of these is different depending on the person in the community, and that's going to therefore inform what type of prevention might or might not work. We've all heard really tone-deaf messaging. I won't go through. Actually, most public health messaging is bad. I'll be honest. It's hard to find good ones that have considered who they're speaking to, the context that they're speaking to, the community or the person. And they consider things like this. They consider that we're all human. We all go through issues like this, and this is going to impact the decisions we make and what we put into our body. And so at the end of the day, we might feel a little like this when we're trying to do this work. And that's not to say that we shouldn't do it, but it can be tricky. And we might feel like this at the end of the day, but there are some definite ways that we can do the work better. And so I'm going to get into that next. All right, so an important thing to remember before I continue, and I mentioned it at the beginning, and I would love to see the chat again. What do we think the role of stigma is in this work? I think go ahead, Ashley.
Oh, I was going to say, we have one answer so far. I'm sure others are typing. One of the challenges to overcome and learn about.
Yep.
The role of stigma, barriers to accessing treatment. The role of stigma is meeting people where they are at.
Great.
Michelle says she loves the integration of wellness. The wellness is an easier message to sell to some of our communities.
Great, and thank you so much. And again, Stigma, we could do another 3 hours on Stigma alone. Larry is on the call. He does excellent Stigma training. So if any of you are interested, please get in touch with me or us at the end. But I wanted to bring it up because I think it's important to mention that Stigma is involved in this work no matter what you do. There's no way around it. A lot of times even you think it's not there and it's there. So you might even be trying to get data, let's say from the Board of Pharmacy, or you might be talking with a school about distribution of your material. And you might think that's a completely straightforward request about handing out material. And suddenly you find yourself in a conversation about stigma because either you encounter resistance, you encounter questions that you didn't think. You know, we get immersed in this work. And I think I'm surprised sometimes when I find resistance to it, or I find unconscious stigma. You know, we all carry around unconscious stigma, whether we want to admit it or not. And so I think the reason I bring it up is that it's in the work regardless. And a lot of prevention work is talking about stigma. That is just the reality of the situation. And in fact, I wanted to mention one of my favorite TED Talks is by Brene Brown, and I'm sure many of you have seen it, about the power of vulnerability. And there's a great thing she says about when she first started her PhD research, and she had a professor who said, if you can't measure it, it doesn't exist. And she thought, this is fantastic. I'm an ordered person. I'm a researcher. I want to take what's messy in life and put it in a bento box. So she was excited about the prospect of I have to be able to measure it. She wanted to get into her research about shame and vulnerability and what makes us connected. And as she said, she thought it would take about a year. And then she said 6 years later of interviewing people about shame and vulnerability, the only solution she could come up with was that stop trying to control and predict and let go of shame and vulnerability. And she said then that's where she needed a therapist. Like, it's practically impossible to measure things like shame and vulnerability, but it doesn't mean they don't exist. And the same would be said of stigma, right? We know it. Or that classic line, I think, from politics where I can't define pornography, but I know it when I see it. Like, it's hard to define stigma in every context, but we know it. We know it when we see it. We certainly feel it. And the example, go with me here, that I like to use is it's if you're a baker or you like baked goods, it's like trying to eat anything with powdered sugar on it, right? It's no matter what you do, it's going to get all over you, okay? And that's the way I feel about stigma and the work we do. It's impossible to avoid. It's going to get on you. You've got to be prepared to talk about it and recognize it. And none of us have it right. Like, again, unconsciously, we might express stigma. There's still stigma within our families and within our institutional systems, within our judicial system, within our provider system, right? There is stigma. Doesn't mean they're bad doctors. It just means it's there. So the powdered sugar example is that it's everywhere. It's unavoidable. All right, so back to our community strategies and how we tackled this work. To the best of our ability, we tried to let the community tell us what they wanted to hear around this issue. And that's not to say we still had some goals from the beginning, which was we need to educate parents, grandparents, and community members about safe disposal, safe storage, talking to family about this issue, and not sharing with family members. We needed a home base, and that is our Little Things Matter campaign. I'm going to get into that in a second, but you will find all this information at littlethingsnewmexico.org. And this is where we wanted that kind of community, provider, media to combine into a home base. So where we could share information back and forth, depending on who you are and what your needs were. As far as parents, grandparents, and community members, you all know strategic partnerships are essential. Some of our best ones were through the Home Visitor Network in Bernalillo County, the Home Visitor Work Group, because they're getting direct access to families, multi-generational families. And so we worked really well with them just about, again, we don't want to add more work for direct service providers, but if they're aware that we're here, we're providing doTERRA bags, we're providing things like lock boxes, we're providing education around opioids, then that just helps them have another tool if this issue comes up. strategic partnerships with the National Guard Counter Drug Task Force, the DEA Take Back Days, ABC Community Schools, grandparents raising grandchildren, the list goes on. I can't list them all here, but those are absolutely essential to get this work done. And then community buy-in is also really important, right? Because as I said, how do you have the conversation with somebody who doesn't think this is an issue? And that's more common than you think, in fact. And I also like to make the point that when I'm speaking about doTERRA, it is not the essential oil. Everyone thinks I'm talking about aromatherapy until I'm more specific. I'm talking about the doTERRA drug deactivation bags. Hopefully everyone on this call has heard of them, but it chemically deactivates the opioids and is a safer way to dispose than flushing them down the toilet. All right. So here's our Little Things Matter Home splash page. And we really wanted, again, to kind of people to be able to find the resources based on where they were coming from. So parents and guardians, young adults, providers, and community members each link to different and overlapping resources. And this is where also, as a preventionist, it really helps if you have a good graphic designer working with you. We were lucky enough to work with Media Desk on this. And just like you're going to be doing stigma work, you're also going to kind of get a crash course in marketing 101 about how you design media around these issues. Because I think one of the best things our graphic design team said to me at the beginning was, if you design a message for everybody, you're speaking to nobody. And so we really needed to tailor, who is a doctor in Bernalillo County? Heck, who's a doctor in the South Valley versus the Northeast Heights? Those are different people. What are they going to hear? What do they want to hear? What might resonate with them? And so here's where persona exercises come into play. So even going around with your prevention team and brainstorming, what is a parent in Bernalillo County know about opioids? What might they need to know? And of course, a lot of this was accomplished by speaking directly to those parents or speaking directly to those providers. But it's really helpful to approach it from this context, or else it feels, again, overwhelming. So here's an example of a product we created. It's actually out of some of our community-based participatory research in our parent guide. And I really like showing this one because this came entirely from community members going, I often don't know what I need to ask in an appointment. So here's an example. You could tear this out, take it with you. You could give it to a family member, and you could go through the checklist. I know even preventionists, right? I've left doctor's appointments and left. What just happened? Like, I don't know what I just experienced, or, oh, I forgot to ask that question. Or you feel like you're pressured for time and you don't have the opportunity to ask the question. And that's another message the community needs to know is community needs to feel empowered to even have this conversation, for one. And that it's not just this patriarchal, I'm giving you this, you take this, but you don't know what it is. We really need to kind of switch the narrative around that relationship with providers. And then I'm sad that it's cut off at the bottom, but in fact, the yellow bar, which is another great thing, the community said, what are my responsibilities around opioids? What do I need to know? What do I need to do in my home to keep my kids safe or my pets safe? And that's things like locking up. And then you can see on the side, we have a little graphic about common opioids. So like we did our little breakdown of Vicodin, but here are a lot of other common opioids. Just to familiarize people with names, because again, there are probably 100 different brand names and different generic names for these medications, and it can feel extremely overwhelming. All right, switching to our provider focus. So the way that we engaged providers was through direct provider education. So that's through something called academic detailing. I hope most people on the call have heard of academic detailing, but briefly, it's based on a pharmaceutical rep model, and I don't really like saying that because you think pharmaceutical reps, what are you selling? But it is true. You really are. You're selling yourself, your resources, your ability as a communicator and researcher to the provider as a community resource around opioid prescribing. And so NARCAD, sorry, that's an acronym, but it's the It's the National, I believe, Academic Detailing Resource Center. I probably got that wrong. But they do trainings on how to become an academic detailer, and anyone from the community can become an academic detailer. And I think that's what's really neat about the model, is because, you know, you don't have to be an MD, or you don't have to be a PharmD or a PhD. You can be a certified prevention specialist, you can become an academic detailer, and you can start speaking to prescribers about this issue. And it'll cover things like safe prescribing, it'll cover things like getting your Suboxone waiver, it'll cover things like community education. How do you have conversations with your patients around this issue? What are the barriers you're finding there? How can we help you? Do you need a poster for your door? Do you need parent guides in your waiting room? Things like that. It is such a great way to get your foot in the door. And it's also a really great two-way learning experience with providers and the provider community. Now, it can be challenging because, again, it's really hard to get time with providers. And so that's where sometimes group education comes in. And we actually work with Dr. Ryan from UNM, who designed Hero Trails. And that's a group provider education curriculum. So if you can get a group of providers to come and have lunch in a room, you can teach everyone at the same time about safe opioid prescribing. Now, that's also going to involve, again, stigma education, education around medication-assisted treatment. I have been in a provider room where we've heard, well, my solution is just not to prescribe opioids ever again to anyone. That can't be the solution either, right? Because cold turkey often is not the answer, and we don't want additional suffering in the community. But one of the biggest challenges with academic detailing is getting the word out that we provide this service at all. So that's where things like connecting with other networks around the state of people who do this work, like Center for Health Innovation, people at DOH, really connecting everyone in the state of New Mexico who does academic detailing, and making sure every provider knows. They could pick up the phone, they could call and say, hey, I'd love an academic detailing session on Friday. I need to refresh my knowledge about the CDC prescribing guidelines. Great, boom, done. And so that's been really, really wonderful. And through that provider outreach, we've also developed a provider guide. I'm going to talk about that in a second. And then also direct pharmacy outreach. So going to the pharmacist, trying to say, hey, we'd love to provide some resources every time you prescribe an opioid. You know, I've been to several pharmacies in the community that actually don't want additional education. And that's tricky, again, because corporate pharmacies can be really tricky to, like, hey, I'm a small nonprofit, please let me educate your patients. But a lot of the independent pharmacies are actually very willing. Say, great, leave some flyers, I'd love to hand them out to people. Whether or not pharmacies have drop boxes, whether or not pharmacies have lock boxes, things like that. And the really challenging thing here, and I think even Tone mentioned it, is we want to be seen as a service and not a burden, right? Because when you call providers and you pester them and bother them, especially during COVID, I mean, I love this picture of showing just what our healthcare workers are going through right now. You don't want to be adding burden to their lives. So we want to make people aware that we are here as a service. If they need something for their practice, for their waiting room, if they need help with talking about this issue, we're here. But they're so busy, they're so overwhelmed. You know, COVID is dominating all of their lives. It's really challenging to walk that line between letting them know we're here and not burdening them too much and turning them off from engaging with us altogether. That's a tricky line to walk. All right, so here's an example of our provider guide, and this was developed in conjunction with feedback from academic detailing. And this is, again, all at littlethingsmatternm.org. So we kept ours as short as possible. That was the most feedback. Providers do not want to read a 40-page document. I think when I first started drafting it, I clocked in at about 30 pages and they went, you've got to be kidding me. So they wanted as short as possible. They wanted it to be easy access for mobile devices. They don't want more paper. And then they want resources, direct link to resources. So even, let's say, a direct link to that morphine milligram equivalent calculator, things like that. And then here's just the lower page of examples of the main tenets of our provider guide. And ideally, also keeping it in a digital format means we can update it as the guidelines might change or the resources might change. All right. And so to our last kind of overall theme of CVPR and social media. So I mentioned at the beginning bootcamp translation, which is really, I think, a really fantastic way to get community input and community buy-in, but it's a series of structured focus groups. And I mean really structured. So there is a plan, there's bootcamp translation training. We were lucky enough to get trained in how to facilitate bootcamp translation. And this means that you have a subject matter expert, usually an MD, who comes in and gives a primer on what are opioids, how do they work, what are prescription opioids, why are they prescribed. And then initially the model of bootcamp translation was designed for chronic illness and chronic disease management. So like screening for colon cancer and diabetes and your HbA1c. And so for an adaptation for substance use prevention, we realized really quick, well, we need an expert on prevention as well. We need a subject matter expert who's really going to nail down, again, what do we mean by primary prevention? Because if you get a group of community members in a room and you say, what do we do about opioids? Everyone goes immediately to treatment. And so even messaging around treatment. So it's really essential that your facilitation team even act like, the blow up bumpers at the bowling alley. The ball's going to veer off into treatment and veer into harm reduction. And we need to steer the group back to primary prevention. And so we were able to do bootcamp translation 3 different times, one with a group of adults in the community, and then more focused with a group of LGBTQIA young people, and then with a group of Spanish-speaking parents. And this was really fascinating. I could go off into another hour about this alone, but it was incredibly fascinating to spend time with these community groups over the course of about 8 weeks. The original bootcamp model stretches over 9 months, but when we did it during COVID, we compressed it so we could have a weekly meeting with the same group of people, with our graphic design team, with our subject matter experts, and the entire goal is for them to inform us of the media we need to create around opioid use in the community. And it was especially fascinating to run a group of young people and parents at the same time, because both the young people and the parents said, we need to talk about this issue more and we don't know how, right? And so that was fascinating that you heard both the young people and parents saying that, but like, oh God, I can't talk to my teenager about that, right? or the queer young person who'd say, I'm already queer, you want me to talk to my parents about drugs? Like, it was really, really, really inspiring, but also informative. And then the goal of the community-based participatory research was that would be informing our social media campaign, our print ads. We created a Spanish language radio ad. We have a downloadable Instagram toolkit. Again, all this is at Little Things Matter. I just wanted to highlight what came of this. And here's an example. So here's some Spanish print media we created, and I'm a non-Spanish speaker, but I know this says opioids don't discriminate. You and your children can be affected. When you receive pain medications, ask your provider, does this medicine contain opioids? What are the risks and what are the safest ways to store and dispose? And how do I avoid an overdose? What do I do? How do I recognize it? And it is your right to be informed, to ask and investigate with your children. And so this is still stock photography because this can be used later if we wanted to purchase and again, make a poster for a clinic. We wanted to distribute. We can work with this in a digital format and we can tailor it to who might need it or want it. I'm going to play our radio ad for everybody. It's not the same as the text, and so I just wanted to make that clear, but I'll just play that.
Cuando te recetan medicinas para el dolor, ¿sabías que tú y tus hijos pueden correr peligro? Los opioides no discriminan. Todos somos vulnerables a las adicciones y nuestra comunidad latina corre mayor riesgo. Hablemos de los opioides y rompamos el estigma contra la adicción para proteger a nuestros hijos y comunidad. Infórmate e investiga junto con tus hijos. Visita a littlethingsnm.com.
Great. And so the really neat thing is that we as a facilitation team or preventionists, we didn't decide to do a radio ad. The community did. The Spanish-speaking parents said, well, where would we be the most likely to hear something around this? And they said radio. Whereas the youth group said, don't talk to us on Facebook, right? You've got to use Instagram or you've got to use YouTube or TikTok or something like that. I'll tell you where teenagers don't hang out: public health Facebook pages. So that's another thing that, we really learned, that even as us as preventionists, we might have access to, our agency's Facebook page. We might post great material and then no one's there to see it. And our demographic group is not there at all. And so how do we really think about this carefully? How do we target where teenagers are going to be? And it's so funny because I'll share another story from the youth group. When we first started this, we had such a great group of young people. They almost initially thought like what sounded the best in terms of like a homework answer. So I said, where would someone be most likely to maybe read something about opioids? And they said, well, let's put a poster up at the gas station, because you're sitting there, you're bored and you're pumping your gas. And I had to put it back to them. When's the last time any of you guys hung out at a gas station? It's like, that sounds good and that might appeal to adults pumping gas, but that's not maybe where LGBTQIA young people hang out. And so once you get their brains thinking in that context, then you get really great product. So here's an example from our Instagram toolkit of an Instagram series. And this is all the young people's content. They created it and we just got out of the way. And I wanted to mention as well, so this is downloadable at our website, that the biggest thing we learned kind of from this process was that they want to create the media and they want to share the media. And so the next step we had to think about was, well, okay, is it going to be just me posting this on an account, or how do we really get out of the way and let them do this? And so that really stems well into the next portion of our presentation that I'm going to let Ashley do about testing this theory, about letting young people really be in charge of this content and supporting them to get out of the way. And I'll just remind everybody, everything I covered is on our Little Things Matter website. So if you'd like to take a closer look, I'd love to hear from you, but I just wanted to give a brief primer. And I'll hand it over to you, Ashley.
Wonderful. Thanks so much, Christine. Before I start, I just wanted to do a quick time check. I know we started a little bit late. Are we still planning to take a break at 1/4 till?
Yes. We'll
Okay.
still take a break at 10:45. Thank you.
Okay. All right. Well, I will do the best I can in the 4 minutes that I have to kind of tell you a bit about how we extended boot camp translation through an addendum. If you want to just go to the next slide, Christine. Really, in our purpose of doing this is such a neat project, and I'm hoping that what you can walk away, and I'll try to focus in these 4 minutes on the take-home messages that you can have, that you can use, that are applicable to your own efforts working with youth, working with LGBT youth like we did, or just working with social media in general. And so we will have the slides and you can read more kind of about the background of the project. Really what we were looking at is, what's the best way to engage LGBTQ and sexual and gender minority youth in, like, as Christine said, getting out of the way. Like, how do we create, how do we provide a space where they can create work that speaks to them and that's created by them for them, right? And so if you can go to the next slide. So we actually did a 4-stage approach, and you'll be able to see more of these in the slides. So we leveraged some data that we had from other prior projects that were not OSAP funded, but had very relevant questions, including mental health in the pandemic, which was, really interesting. Then we mined the bootcamp translation process and some of the notes that we had for that. We did focus groups again with the youth that initially participated. It's like, what are your reflections on that process and what do you want to see going forward? And then we created an internship program with a community-based participatory research action approach to engage leaders, 2 leaders that kind of bubbled up from the group that we had worked with in the bootcamp translation process, and then disseminating that as well. So I think I'll skip the next slide about some of the previous work, but I'll leave in the notes section some of like the interesting things that we found that I think are really relevant to the work that we're doing across New Mexico. we had lots of lessons learned, and I mean this from the previous work that we did, from the focus groups, and from mining the data from bootcamp translation. And so we have on the next few slides, what we learned and what we did with that information. So, things that when you think about them, they sound like they make sense, but, how do you put those into practice for a public health campaign, right? So for example, we know that peers go to other peers for informal psychological supports, and this was very, even more common during the pandemic. So, we really turned our attention to developing an approach where we could give youth the, access to reliable information, because we knew that peers were going to go to them. And so, how do we talk to youth about distinguishing them as a safe person to talk to, and that someone who has access to reliable and accurate information, and it also is going to share that information in a way that's not stigmatizing for intersectional identities. Another thing that we learned is with intersectionality, that LGBTQ status is one part of their identity, but that bifurcating information by any of those letters was not going to be successful in terms of, having people first identify there and then going to substance misuse related information and prevention information. So we wanted to focus in on how we could have more inclusive messages that reach the broader audience. And also we learned, how important privacy was. I mean, so this was conducted during the pandemic, and so we didn't have the option of a face-to-face, but what we learned, that even when face-to-face, even outside of the pandemic, that many youth felt that school-based health centers had some other concerns related to privacy and accessibility. And so that we really had an opportunity to engage youth in private online spaces. And that youth go to the slide on online engagement, Christine. There was a decline in supports overall for LGBTQ youth throughout the pandemic, which, for everyone. But that, online support is really a source of, information and peer-to-peer support. And so we wanted to focus on online engagement instead of something else like print or one-on-one kinds of mentorship or other kinds of engagement. And that the home environment feels a little bit safer. So your school-based efforts were maybe less likely to be successful when youth already feel unsafe in the environment. And so rather than going through schools and doing school-based efforts, to have something that would be accessible online through a more private space. And then really just drawing upon these insights. And then for prong number 3 was, creating this youth opioid use prevention ambassador program. So it was 4 weeks long. It met for 3 hours a week, 2 hours on Mondays and an hour on Friday, between the weeks of June 21st and July 19th. And we took a break over the week of the 4th of July. The youth created a number of social media materials, as well as an Instagram account that goes with the bootcamp translation. So on Instagram, if you're not already friends with Little Things Matter NM, when I put together this part of the presentation, we already had 10 posts, 42 followers, and 84 links with individuals and organizations doing related work around New Mexico. That's a lot in 4 weeks to do some pretty intense training and to get the youth and to have a product that's already, starting to take shape and inform its own life on Instagram. And somebody actually had already reached out to the site to ask about the availability of the local availability of Narcan. And so I think that really speaks to the need for engaging in these online platforms. Also, I think Instagram is something that people who are a little bit older, such as myself, don't necessarily, are not as comfortable on that format. And so it was really great to kind of see and to really engage youth where they are you know, and to train the youth and see their confidence rise through the ambassador program to be able to serve as really as ambassadors to their own communities. So the project was a success. We'd love to do more of it. So the big, you know, the big number I'll drop is we had 17,589 impressions. So those are not necessarily deep engagement with our content, but you know, we engaged about 9,800 folks, and we have about 31 people who regularly engage with us. We also learned something interesting, which was our shares are higher than our likes, because we think that people are, that there's probably still some stigma element to it, but that people do see the information as valuable and will share it more often than they will publicly maybe associate themselves with the post. We reach slightly more women than men. We utilize paid ads, and we're able to reach our target age range through them. And then, so here's some just last little points of news you can use. You know, Wednesdays and Fridays were generally pretty good days for us to post. So if you're trying to reach youth, you could start there. You know, you can schedule posts. So those are good days to start, Wednesdays and Fridays. Things related to education, Fridays at 10 a.m. tended to be a good time. And if you're trying to reach like healthcare providers, Tuesday at 8 a.m. Tended to be a good time to reach them. And so definitely, you know, one thing that we learned to share is that we want to bifurcate messages to activists and preventionists versus youth. And so through this Instagram, what we found is we either engage one or the other. Some posts engage the health professional community and others really engage the youth. And I think that that just echoes what Christine had said. If you try to talk to everyone, you're talking to no one. And so anything where we want to engage youth, we believe, you know, through our experience doing this project, it needs to be for them, by them. I'll pass it back to you, Christine.
Great, thanks. I know we're over, so just really quickly, last thing. So Ashley just said that media bias for us. Centralized resource hubs would be great so that people could go and get the resources that they needed. Making it universal. That's again, a lot of parents think that they don't need to talk about this issue, but yet everyone has a smoke alarm in their home. You know, we all need to know about this issue just in case. It doesn't mean we're playing with matches, right? Make it universal. And the last note about data and COVID, right? It's really hard to do this work during COVID, especially with providers. And so we know some of the data might not reflect the work that we're doing because it's hard to collect data around this issue. I'll ask if anyone has any final questions. I just wanted to use another picture of Prince. And here's our contact information. Please, please, please reach out to me. I would love to talk to you more about any of these strategies, any of the work that we've done. I've learned a ton by networking with people at these meetings. So please reach out to me, and I'd love to chat with more preventionists in New Mexico about how they're doing this work. Thank you all so much.
Thank you, Christine. Thank you, Ashley. At this time, we want to go and take a quick break. We're going to probably take about maybe 8 minutes so that we can come back and start up at 11 o'clock. Also, what I'm going to do is I'm going to kind of do a quick run through of a couple of things as we start the next presentations, but please take a break. You don't have to log out. You can just step away and we'll reconvene at 11 a.m. So see you soon. Thank you so much. As we're welcoming everyone back, I wanted to share with you really quickly, if possible. Can I share my screen real quick, please? Hello?
Yes, you can go ahead and share your screen.
Okay, oh, there it is. Sorry, my bad, my bad. Okay, what I wanted to share real quick is a slide on Partnership for Success 2020 grant. I wanted to mention that the purpose is to reduce polysubstance-related overdose death in New Mexico. It serves adults at high risk of overdose, particularly Hispanic and Native American men, also middle-aged white women. Where are we going to work on this grant? In Bernalillo County, Doña Ana, San Juan, Sandoval, Santa Fe, and Valencia counties. So shout out to PFS 2020 recipients. And as you can see on the bottom, providers have a lot of local expertise and knowledge in harm reduction, which is definitely what we need. And so just wanted to give a shout out to them. I know we also would like to have some time to share a little bit about what's happening in the chat, because there was so much information being shared. So I want to mention all the slides will be sent out. First of all the slides will be sent out. I did write out the acronym of NARCAD, National Resource Center for Academic Detailing. There was a shout out to Silver City leading academic detailing in our state and beyond. Liz mentioned that one of the parent participants heard the radio ad on the radio. Everybody is just really excited about the presentation that Christine and Ashley gave. And of course, SOR can provide training and Narcan for youth. Bernie Living is the contact for that. Let me see. So I believe there was a question in regards to whether youth were, if there was some funds paid for the youth to participate, and there were. They saw it as a summer job, and it was helpful to share materials, etc. So there was a process set up for the youth to be for it to be considered like a summer job for their participation in the youth activities that were happening with the Health Equity Council. Thank you. Sorry about that. So I want to go straight into. We had time, we were going to do time for a poll, but I don't think we're going to. What I want to do is kind of just say welcome back. Hello. Our next presenters are from the Pacific Institute for Research and Evaluation. They will be walking us through the fiscal year 21, FY21, New Mexico Community Survey results. Before I hand it over to them, I want to acknowledge all of the wonderful and creative work PIRE has done to support us in collecting the New Mexico Community Survey, despite all of the challenges related to COVID-19. Thank you to everyone at PIRE for your continued support to make the collection of the survey possible, and all, everything that has gone on. I know this year has just made an impact on results, but we'll also I'll allow you guys to talk about that. And I would like to hand it over to Liz, Lilliet, Dave Curry, Marisa, and Ashley from PIRE.
Thanks a lot, Tone. I really appreciate that introduction, and I appreciate we all appreciate the appreciation. So can we pull up the slides? My job is just to introduce my team and then the general presentation. I am Liz Lilia Gonzalez. I've been working with OSAP for about 15 years now here in New Mexico with the Southwest Center for PIRE. I work also with a team of folks who are in North Carolina PIRE offices. They include Dave Curry and Ashley Simons Rudolph, who's here, and I'm kind of scanning through my list. Go to the next one there. And the rest of the folks are here in New Mexico. We have Emily Houses, Cristina Lopez Gutierrez, Marisa Elias, Maria Elena Reyes, and Martha Waller, who was our guiding light for many years and still remains in the background, and Kim Zamarin and Lei Zhang. So everybody here on this list has participated in one way or another with the community survey. This last year, we kind of went through a grand revision of it, or a sort of improvement of it, where we gathered together the local evaluators and really gained a lot of great insight from you all, and then before we went to the SCOW with our proposed changes. So hats off as well to the local evaluators who helped us improve this whole process. So folks here on this list participated in IRB applications, development of survey questions, improvement of survey questions, managing the website, managing the protocols, managing your protocol reviews, answering your questions, coming to action at the moment that we noted some trouble. Anyhow, you will hear a great deal about that ahead of time, but I just want to thank this incredible work that went into making this survey happen, as well as, of course, every single community preventionist out there who has put your voice and your efforts behind making the survey work. This is your survey. So thank you very much. And the next slide is just sort of the survey, the summary of our presentation today. And I just want to say, put your questions in the chat or the Q&A, but the chat, everybody will see. The Q&A just goes to the panelists, and Ashley and I will attempt to answer your questions as we go along, as we did before. The topics we're going to discuss today are the changes to the methodology during the pandemic, our statewide sample this year, alcohol trends, prescription drug use trends, the opioid module, the marijuana module, mental health module trends, the PFS 20 module, and then open-ended question and responses. And I believe that you all received a summary report this year of those results as well. So I believe they went out on Friday. And those will all be on the website, as this presentation will also be. So with that said, I will pass to the next presenter, who will be Ashley.
All right. So those, for everyone who is not Karen Chayman, those results came to you on Monday. My part of the presentation, just kind of, leading us off here, is to talk about, oh my goodness, we're in the second year of the pandemic, impacting the community survey. We already know that we can't reach everyone in our community online. What do we do? And so, unlike, we had a little bit more time for planning in 2021. We're a little further in the pandemic. It didn't catch, it caught us. And then there was some literature about what are the best practices for online engagement. So, I'm here just to talk about the approaches that we took to recruitment this year, and some of the same and some different things, and kind of how it worked. So 93% of our sample took the online survey this year. So almost everybody, and PIRE employed the usual state level recruitment methods and added 3 additional ones to that this year. So we took 5 approaches that are represented on your screen. So we recruited through social media, and particularly through paid social media ads. That was Facebook and its relations, so Instagram, Facebook games, which we'll talk about in a minute. We increased the number and spread of print materials, including flyers, handouts, and posters that were double-sided and available in Spanish and English. We engaged participants, linked with Ricardo Cartier, who's a New Mexico artist, and we sampled through a paid Qualtrics panel and used ads that paid participants to learn more about the survey. The first couple that I talked about, the recruiting through social media and increase and Print ads were things that we had used in the past, and everything else was new for us this year. So same as last year, we offered weekly incentives to randomly selected individuals who completed the survey. After completing the survey, respondents were invited to enter to win an incentive, but this was optional because it required them going to another platform for that way it would be disconnected, their identity would be disconnected from their data. And not everyone who filled out the survey chose to go to that optional page where they could enter their personal information so that they could be eligible for the drawing. So each week, 3 $100 checks were given away to randomly selected participants who completed the survey during that week. And at the end of online data collection, we gave out a final $500 check. All of that was posted on our Facebook page, and people were given a shout out. So we, hope to kind of increase the word. So we'll go to the next slide here. I want to talk about each one of these in turn, and especially the new things that we did. So, the recruitment ads on Facebook, Instagram, and Facebook-owned online gaming platforms, which include stuff like all the Candy Crush spinoff games, for example. So Facebook has an algorithm that they just want your money, and they'll tell you how to best use it. And so we played with the algorithm to see how we could best target different kinds of audiences and different demographics of audiences. So all ads targeted New Mexico residents 18 years and older. 12 of the social media ads were in both English and Spanish, plus there were 7 in English only. So 31 ads were run on Facebook, Facegram, that's pretty much it, Instagram and applications. We maximized the timing. I know I talked in the last presentation about, when is the best time to send out messages for call to action. And so there is some literature on, who's on social media at what time. And we did use those best practices. And then we have a, system of metrics where we would review, are we reaching the people that we thought we would reach? And are those people converting, meaning are they going on to complete the survey? Ads were created targeting young adults, parents, Spanish speakers, members of marginalized groups who are less likely, at least in national surveys, to participate in survey research. And we used various formats like storyboards, animated videos, static photos, and we amplified paid advertisements. We, based on, sampling in previous years to engage men, Spanish speakers, and those living in OSAP funded zip codes that are not being reached by other recruitment methods. And we worked with our local evaluators to identify those zip codes, because we know that some programs are working in things that may be zip codes that might be slightly outside the county, but are still part of their program. Yes, those were included. The ads ran between March 16th and May 9th. And over the 8 weeks, we ended up having 282,701 impressions. So a lot of people saw our ad. And we had, 5,000 from that resulted in 5,001 unique clicks on the survey itself. So, fairly successful ad campaign. We also increased the number and the spread of our print marketing materials. We had done posters in the past. This year we did posters and hand cards and 8.5 by 11 flyers. Everything was two-sided. In the past, we had done like some Spanish, some English, but we wanted to make things as easy as possible for the communities and all of you wonderful people that helped us by posting those things. So everything was two-sided. We mailed it to preventionists at an address of their choosing. In most cases, that was their home residence. And we relied on you to distribute widely around New Mexico. Some of the interesting places, where things were posted were COVID-19 vaccination sites. We again got permission to post at the motor vehicle department. As you can see, here is a picture that my colleague Kim Zamrin took. And the caption is mine. This wasn't actual real qualitative data, but the point was to get this, people weren't out in public a ton. And so to get this in spaces where people had to be out and about and were waiting, thinking that they could just quickly take the survey, while they were there. So things like bodegas, laundromats, grocery stores, anything where people might be waiting in line. All the materials had the teeny URL and the QR code. All right, I'm gonna go to the next slide. So let's talk about some of the new stuff that we did. Our partnering with Ricardo Cartier. He created 4 paintings for us related to the survey and promoted them on his personal social media, which he did 3 times over the survey period, and on his weekly radio show on KSFR. This was such a cool way to amplify information about the survey. And so his first post received 575 engagements. And so that's actually people liking it, commenting on it, sharing it. 150 just shares. So we got 153 shares. So that was really cool to see the engagement. He posted again on April 9th and the 30th, and they still, even the second and third time he posted, the engagement was still really high. We're going to talk through some of the other approaches, but I wanted to just show off Ricardo's beautiful artwork here. So the next couple of slides, you'll see we'll have the artwork while we talk about some of the other kinds of sampling or some of the other kinds of recruitment approaches that we use that were somewhat less beautiful to put on a slide, so we should speak. So another thing that we did is sampling through a paid Qualtrics panel. We employed Qualtrics, and they're the folks that service data capture for the community survey and engage their paid panel of recipients. So we initially contracted for 333 responses, all from men and in diverse age and racial groups. They ended up, a Qualtrics error, overburdened the link, and the site was closed for a couple of days during data collection. And so in response, we got Qualtrics to agree to collect an additional 750 responses at no additional cost to us, to OSAP. So, we ended up getting, about 1,000 folks, just over 1,000 folks from Qualtrics. We also engaged AdWallet, a New Mexico-based company, to run ads to their communities. So basically the way AdWallet works, if you're not familiar, is it pays participants to watch a short ad or a commercial online and then answer a question about it. So through AdWallet, we first targeted Hispanic adults and later all adults who met eligibility criteria for the survey. So AdWallet engaged 10,663 viewers with, and then AdWallet asked some questions like, did you like the ad? And 85% of folks reported that they liked engaging with the ad. So about 5,640 individuals noted that their intent is to go to the survey website within the survey period. There's no way to measure, because they go to the link, there's no way to measure how many actually completed, but we do know that intention is one predictor of behavior. So, so we assume that we got a fair number of respondents from Qualtrics. And with that, I will look at the chat. I see there's some questions, and I'll look at the chat and pass this over to Dave.
Thanks, Ashley. And I think there's one more slide of the artwork that was done. We'll leave it there for a second. And I guess I'll just say hello to everyone this morning. Definitely a bit disappointed, like I know many of you are, that we aren't able to get together in person. For those of us who don't see each other all that often in person, it really is great to get together, and I hope that does happen again sometime soon. And though I do think that it's been fantastic that we've been able to keep this up and do this during the pandemic. So the next slide, please. Okay, so I'm gonna come in at a few different points and say a few things. Marisa is really the one who's gonna lead us through most of the presentation today about the results. But my first little piece here is mostly just reminding you all that we did put together a document this year that we sent out a few months ago that describes the sample this year and the samples we've had during the pandemic and looks at some of the differences between 2020, 2021, and also the year before the pandemic, 2019. And in doing so, hopefully cover some of the ground about what we know about how that sample has changed, where some of the issues are, where we have issues with differential representation of certain populations, and what that means, and some things to think about. So I encourage you all to go back to that if this continues to be something you're interested in. If you did not receive that document, please let one of us know at PIRE and we can make sure you get that. But I'm just going to do just a quick little reminder about a couple things. So going on to the next slide. These are just a few of the things that document goes into. And it's just a good way to be thinking about what the sample is that we have from this year. And with that, I guess I'll just note that with any data that's collected, anytime you're looking at any information, it's always important to understand where that information came from, because there's always limitations to any data. There's always strengths and weaknesses to any data, and knowing what those are, understanding them is very important. And so for purposes of our survey, it is important to note that our sample was more male this past year than it had been the year before, but it's still disproportionate. And we've always had that issue, really. It is difficult to recruit males for any survey. And as a male, I'm a bit embarrassed about that, but it is so true. And we have that issue as well. We did do better this year. You'll see when we look at the next slide, but let's not go there yet. But still, it is disproportionate and important to acknowledge. We have underrepresentation of young adults. Before the pandemic, we actually had overrepresentation of young adults. And a lot of that was due to having a lot of partners who were universities, who had funded projects, who were helping with the data collection. That dropped off within the last 2 years. And so we've gone down to where last year it was a lot more like the general population of young adults. Our sample was about that same size. This year it was even lower though. So we had an underrepresentation of young adults. We still have an underrepresentation of the older population. That's one that's always been a bit of an issue. And it certainly has not gotten better during the pandemic. We've seen it drop even in those who are more the elderly population and their participation. We have an underrepresentation of Latinx Hispanic population. That's always been a bit of an issue. And again, it hasn't gotten better during the pandemic, and we still have an underrepresentation there. And then the other issue to definitely acknowledge is that we still have high levels of post-high school education amongst our sample. And again, that's always been an issue. It got worse during the pandemic when we were doing so much more of the recruiting and participation online. So going to the next slide. Here you just see what some of those actual numbers look like. You can see that male percentage did go up. We made more of a concerted effort that way, as Ashley noted, and it did respond. But you can see some of the other issues we have. In no cases are these tragic, really, but they're all important to acknowledge. And going on to the next slide, acknowledging it, part of what is key is we can do some things to help adjust for differences that we see that are based on some of the characteristics of the demographics of the sample. So we do weight based on racial categories, age categories, gender categories, and that helps account for some of these differences we see. So by and large, it is not that big of a deal that we have more females than males participating. What it means is it's less efficient. The estimates we generate and what we do is less efficient than it could be. But it does not really bring those estimates into major question, because we can do weighting that helps adjust for that. However, the key thing really, the key thing I think that's the take-home message is we can't account for everything and adjust for everything. And one of the key differences by far, one of the most important is that this is mostly, almost exclusively being done online. So all of the recruiting is online. So those who are not recruitable online or hard to recruit online, so let's just say like the homeless population, they're not going to be represented really in our sample, and no weighting is going to be able to adjust for that. The participants had to be willing to participate in a survey and be recruited to be able to do it, and they had to be able to complete it online. So in terms of the able, that's part of the issue with recruiting older participants, I think. And the willing certainly is an important factor. They had to be willing to do this, and many people just will not participate in surveys. So that's all important to keep in mind. The other at the bottom there is just noting, that this does provide, though, very important information that can be really valuable in terms of understanding where things are at the moment within the state. That one of the great things about the community survey is we're able to do this and turn around the information very quickly. So the information that's going to be reviewed by Marisa is from just this spring. And very often surveys like this take quite a lot longer to get out to the public. This gets into people's hands very fast and is a good way to understand where things stand within the state at the moment. And it's a good way to understand a bit about what we've seen during the pandemic, because we have both this data point and from last year's that were definitely influenced by the pandemic, important years influenced by it. They should always be used, as with any source of information you're looking at. You should be looking at multiple pieces of information when making decisions about what it means. And so we encourage you to look at other sources of information as well and compare it to what we see with the community survey results. So on to the next slide. All right, I'm turning it over to Marisa at this point.
Thanks, Dave. Hi, everyone. Unfortunately, I can't see you, but it's good to know you're out there. I am Marisa, and I am with the PIRE team. I'm going to walk us through what we thought are some highlights or just sort of takeaways from the community survey this year. And as a reminder, if you didn't receive the summary report that was sent out yesterday, please let someone at PIRE know. We'll make sure you get that. And also, as you have questions, we have quite a bit of things to cover, so I'm going to try to move through as efficiently as possible. But as questions come up, feel free to drop them in the chat, and someone from the PIRE team should jump in and help answer those questions. But in this slide, we are looking at alcohol use behavior. So we're looking at past 30-day alcohol use, we're looking at binge drinking, and we're looking at driving under the influence. And so in fiscal year 21, we did see a slight increase in past 30-day alcohol use in the total sample. And as far as binge drinking, also another slight increase, not big leaps, but some increase, definitely. And then when we look at past 30-day drinkers, or what we're calling current alcohol users, the binge drinking percentage in fiscal year 21 was fairly similar to fiscal year 20. But something interesting is both fiscal year 20 and 21 are lower than what it was in fiscal year 19 among current drinkers. And then looking at driving under the influence, 2.5% of the total sample in fiscal year 21 self-reported driving under the influence. And then 4.8% of current alcohol users reported driving under the influence. That saw a slight decrease from fiscal year 20 and a major difference from fiscal year 19. And then the last part there is past 30-day driving after binge drinking or 5 or more drinks. And that was at 2.3% for the total sample with a slight decrease from previous years. We can go to the next slide. Here we're looking at perception of risk of consequences and perceived access to minors, and this is still for alcohol. Those top 3 rows are the likelihood of police breaking up teen parties, police arresting adults for providing to a minor, or the likelihood of being stopped if driving intoxicated. So again, we're looking at what individuals said they felt would be very likely. And just to note here that we do see a small, or yeah, we do see some decrease in perceived enforcement. And then in the bottom 3 rows, we're looking at perceived access to minors. We also see a decrease in the perceived access, social access to alcohol by teens. It was at 32.8% for fiscal year 21 compared to 34 in the previous year, and then 42.3% in fiscal year 19. As far as easy retail access to alcohol by teens, there was not much change from fiscal year 20. And then the percentage of individuals who reported providing alcohol to a minor in the past year did see a slight decrease, so that's good, but just something to note. And then we can go to the next slide. Just if there are any questions about the alcohol use results before we move on. And while you all drop those in the chat, I think what we have coming up is a poll before we move into prescription painkiller use results. So if we can go to the next slide and initiate the poll. So the question will be, what percentage of all community survey respondents reported using prescription painkillers to get high? And what do you think that percentage is? And I am not able to tell if the poll is launching.
I don't see it yet. Jennifer?
Do you want to use the chat or?
Well, I think we have a poll. Here it is.
Oh, there it is. Okay.
So we'll just give everyone a sec.
All right, Marisa, you do have a question in the chat.
Oh, let me get that. All right, I'm going to punt that over to Dave or Ashley. I don't think Lay is on, but Dave, do you want to jump in to answer the question before we look at the poll?
Sure. Yeah, I don't believe we have done inferential assessments like that, which is what the question is about. But we certainly can, and if there's interest in that, we can do that.
Thanks, Dave. All right, so on my end, I can see the results of the poll, and it looks like the most popular answer was 12.2%. Well, let's see who did their homework and looked at the at the summary report yesterday with the limited time that you had to look at it before today. So let's go on to the next slide. All right, so looking at prescription painkiller use behaviors, if we want to skip right ahead to the second to last row, the answer is 2.5% of community survey respondents said that they had used prescription painkillers in the last 30 days to get high. So that was the answer, was 2.5%. But starting at the top, the prevalence of receiving a prescription painkiller in the last year was 18.6% in fiscal year 21. So that did see a decrease compared to previous years. So that was receiving a prescription painkiller in the last year. Then looking at the percentage who used prescription painkillers in the last 30 days for any reason was at 15.1% this year, which saw an increase compared to previous years. As far as the average number of days that prescription painkillers were used, when individuals said that they had used in the last 30 days, the average number was 9.9 days. And of the last 30 days, 9.9 was the average number of days that respondents used prescription painkillers. As far as past 30-day, so we looked at prescription painkiller use to get high for among the total sample, it was 2.5%. And then looking at past 30-day users, that percentage is higher at 17% compared to the total sample percentage, but it did see a decrease from fiscal year 20 and fiscal year 19. I think there are some questions in the chat. Oh.
You're fine, Marisa.
Okay, thanks. All right, we can go to the next slide. So here we are looking at prescription painkiller misuse, the perception of harm, and then also looking at sharing or safe storage of prescription painkillers. So something to note here is as far as perceived risk of harm of misusing prescription painkillers, that's looking pretty good. If you look at the percentage of individuals who felt there was moderate or great risk. So that's a good thing. As far as giving or sharing prescription painkillers in the last year, 4.9% of community survey respondents said that they had shared, and 38% had said that they had locked them up. So definitely some room for improvement for both of those. And if anyone from the PIRE team wanted to jump in at any point, please do so. And I think we can go to the next slide. Okay. This one gets a little busy, but what we are looking at here is provider education, and then looking at, and it looks like it's a little bit cut off, but access to naloxone. So starting out with whether a healthcare provider or pharmacy staff spoke to you about risks of using prescription painkillers, and this is among those who reported they had been prescribed prescription painkillers in the last year. Oh, and before I skip it, so of those who had been prescribed prescription painkillers in the last year, 20.3% said that they were also prescribed naloxone. As far as talking about a provider talking to them about risks in using the prescription painkillers, in 2021, 52.7% of those individuals said that a healthcare provider spoke to them about risks, and 34.6% said that pharmacy staff spoke to them about risks. As far as safe storage, those percentages are much lower. Healthcare provider, 31% of individuals said that a healthcare provider spoke to them about safe storage, and 26.3% said that pharmacy staff spoke to them about safe storage. And as far as having access to naloxone when using prescription painkiller in the last 30 days, so that's different from it being prescribed, but then having access to it, that is 32.7%. And I'm going to correct myself because earlier I reported, I think, the 2020 result for being prescribed naloxone, which is actually 25.8% this year compared to 20.3% last year. Okay, we can go to the next one. And now what we're looking at is we're still talking about opioids, but this is the results of the opioid module. So just as a reminder to everyone that the modules, these additional modules, are selected by communities. So these are the results of those communities that selected those modules. So with the opioid module, I believe we had a total of 6 counties who used the opioid module this year. And so here, what we are looking at is 2 things. We're looking at some questions about prescription painkillers and then some questions about heroin. So the top 2 rows are how many individuals reported that having family members or friends who often use prescription painkillers. That was 21.6% of respondents of this module. Of those respondents, they were also asked whether those prescription painkiller users, whether they felt they were at risk of overdose, and 60.7% of those individuals said they felt that they were at risk, that those users were at risk of overdose. And then when asked if those who use prescription painkillers that you know of live with you, 16.3% said that. And then looking the same questions, but now about heroin use. So asking about having family members or friends who often use heroin. That was 9.1% of respondents to the opioid module questions. And whether those heroin users are at risk of overdose, 90.2% said that they felt those heroin users were at risk of overdose. And just briefly, I'm going to point out the difference between that and then feeling that prescription painkiller users are at risk of overdose, and which I think the drastic difference between those two was similar last year as well. And then as far as some of these heroin users living with you, that was 10.8% said that. And I believe that was all on this slide. So we can go to the next one. And then here we are looking at the endorsement of issues related to opioid use. So some questions about whether respondents agree or strongly agree that medical treatment can help people with opioid use disorder lead normal lives. 88.6% said they agree or strongly agree. When asked, my community is not doing enough to prevent opioid misuse and addiction, 78.5% of respondents agreed with that. As far as supporting increasing public funding for opioid treatment programs in my community, 87% of respondents of the opioid module felt they agree or strongly agree. And so one thing is to know is just that for the communities that use this module, and just to have an idea across, these are helpful baselines or ideas of community readiness and awareness as far as opioid use prevention. Yes, I agree. Those are good numbers. Okay, we can go to the next one. Oh yeah, and this one got switched. So if you were paying attention to the last slide, do you remember what percentage of the community survey respondents for that module support increasing funding for opioid treatment programs in their community? Do you remember what that percentage was? And I guess just to highlight that it was a good percentage. And I think we don't have to take too long on that, yeah. All right, we have some good short-term memory. All right, yes, the right answer was 87%. All right, we can go to the next slide. So just briefly, this slide in here, as we move on to the next few slides that report on some of the results for some of the other optional modules, we did just want to point out what the category for female and male, how that was determined for the purposes of this presentation. So responses of female or transgender woman, either alone, together, or in combination with the response non-binary or another category, were classified as female, and then the same was done with the male category. Okay, we can go on to the next one. So we are looking now at the marijuana cannabis module, and I believe there were 8 counties who used this module this year. And so here we are looking at marijuana or cannabis use in the last 12 months, in the last 30 days, and then also some driving under the influence of marijuana and sharing marijuana. So overall, almost 30% of respondents who responded to this module said that they had used marijuana in the last 12 months. 24% said in the last 30 days. As far as driving under the influence of marijuana, of the total sample of respondents of this module, that was 6.8%. And then that percentage is higher among those who said that they had used in the last 30 days, to almost 30% of current users who said that they had driven under the influence of marijuana. So that's something to note. And then as far as sharing marijuana with underage youth, that was at 2.7% said they had. And we can move forward. So here we're looking at the perception of risk of legal consequences, and then also the ease of access by teens. So the likelihood of police arresting an adult for providing marijuana to someone under 21. We want to focus on those who said very likely, somewhat likely. There were some who said they didn't know. So that was also interesting. And then as far as likelihood of being stopped by police if driving under the influence of marijuana, 9.1% said it was very likely, 23.6% said somewhat likely, almost 20% weren't sure. As far as not very likely, that was 33.2%, or not likely at all, 14.4%. So just some good baselines, this and then the previous slide to have, especially with the recent legislation around this, and those programs and communities interested in preventing marijuana use among youth. But the last thing to look at in this slide is just the ease of access to marijuana by teens in the community. Almost 50% felt it was very easy for teens to access marijuana in the community. So we can go to the next one. As far as marijuana misuse prevention support, something that I thought was really interesting was marijuana use by teens is a problem in my community. Something that stood out with that was 41% weren't sure. And to me, or at least I think that's a good opportunity of what education could be, where education could really be beneficial. As far as supporting local efforts to prevent marijuana use by teens, there was more support for that. So 36.8% agree, almost 30% strongly agree. So that's good. As far as driving under the influence of marijuana is a problem in my community, 52.5% said not sure. So that was also really interesting, given the earlier slide about how many, I think it was almost 30% of current users reported driving under the influence of marijuana. And then and then for agree or strongly agree, it's a little higher than those who disagree. And next slide. And I think there's some activity in the chat. I don't know if that's being taken care of by the Empire team.
Yeah, we're watching it, Marisa.
Cool.
Listen, yeah.
Great, thank you. Here we're looking at sources of marijuana by past 30-day users. So either the more popular responses, this is a select all that apply question, I believe, but the more popular answers were purchasing it in a state where marijuana is legally sold, purchasing it in New Mexico using my medical cannabis program, and then it goes to someone unrelated provided, and then bought it from someone following that, family member provided. So just interesting to see, and I think especially for those counties who use this module, who might live close to the Colorado border, just looking at purchasing it in a state where marijuana is legally sold. And I know there's been legislation changes recently, so it'll be interesting to see what it looks like next year. Okay, next slide. Looking at reasons for consumption by past 30-day users. So the more popular responses here were to cope with anxiety or stress, to help me sleep, and then used it for medical purposes in accordance with my medical cannabis card. And then following that, used it to address a medical issue, but without a medical cannabis card. So that just really shows that it's really mostly being used for medication or to self-medicate. And with that, actually, the next slide, thinking about this next slide, is about the mental health module. So the mental health module, I believe, was used by 9 counties this year. And so looking here, I think that the big things that stand out is percent who sought help on mental health or drug alcohol problems in the last year. In fiscal year 21, that was 22%, which saw a dip from fiscal year 20. And, you know, that makes sense with just barriers to access to medical help. And then also looking at having difficulty accessing treatment for mental health or substance abuse problems. There was, yeah, a jump in the percentage there who had that difficulty. So makes sense with the previous percentage. But at 12.4%, increasing from 8.9% in fiscal year 20. And also an increase from fiscal year 19, which makes sense. And then as far as for percent meeting critical threshold for serious mental illness in fiscal year 21, that was 13.9%. Percent self-identified having mental health or drug alcohol problems in the last year. Not a big change there from fiscal year 20 at 34.2% fiscal year 21. And then lastly, the percent of suicidal thoughts in the last year, still concerning, but not much change from fiscal year 20. And I believe with that, I'm going to hand it over to Dave to cover the last module we're going to cover today.
So yes, thanks, Marisa. The next slide, please. Oh, and actually, given time, my guess is what we'll try to do is just handle questions at the end because we're getting very close to the end, but I think we want to make sure we get there. So the next slide, please. Okay. These are items that were added because of the focus of the PFS 20. And one of the really key things to understand is that 2 of these items were asked of people regardless of where they were responding from. So they have a really a statewide sample. And those are the 2 that are a little bit more bolded, and they have the ends that are larger. So the past 30-day methamphetamine use and the past 30-day polysubstance use. And those are the 2 I'm going to key on the most. The others were asked just of the 6 counties, and they're the largest 6 counties by population in the state that are part of the PFS 20 statewide initiative. And so those those are statewide estimates that were generated, but they're based just on the most populous locations. So that's something definitely to bear in mind when looking at those. Again, these other 2 that I'm going to focus on the most were asked of a more representative sample across the entire state. And so I guess the other thing I'll note is just for polysubstance use, it has a very particular definition, and that's 2+ of the list there of substances within 2 hours. That was how it was asked. And so you can see what that is getting at, because obviously polysubstance use could be defined in many, many ways. This is how the question was asked and how it was defined for purposes of this question. I guess the big thing to me really is that obviously with methamphetamine, we don't expect there to be huge proportions of the population engaged in using methamphetamine within the past 30 days, but it is one of those things that is incredibly high risk, both to the user, to their family, to the community, in terms of the cost potentially to themselves and to others, really. And so that 2% overall of adults, that's our estimate based on the data we received. The 2% of adults in the state have used methamphetamine in the past 30 days is definitely troubling. And you can see it's 3% for males, so that's very troubling there. The same sort of pattern of really being concerned about high risk use is the case for that past 30-day use for polysubstance use. It's 4% of the population. Again, it's not a huge proportion of adults, but that is a very risky group right there, and one to be very concerned about. And that, again, 5% of males fall into that category is something I think that should be concerning to all of us, and obviously is part of the reason for why the PFS 20 is focused on what it's focused on. So I think the next slide is qualitative results that Ashley's going to cover.
Thanks, Dave. Okay, so as in the past, we asked, is there anything else you'd like to tell us about the issues we've asked you about today? And it's a free space where respondents can put comments in the box below. We had more comments this year, 3,530 compared to 2,477 last year. But once we subtracted what we consider sort of analytically empty comments like no, or not at this time, NA, thanks, good luck, as well as anything that was like uninterpretable, like some people try to put emojis in there and stuff like that, and they're not read by the software. So we ended up having fewer comments this year. So we ended up with 1,823 comments as opposed to 2,377 last year. And fans of the presentation, of this annual presentation, will note that last year we got a lot of comments, and we got a lot of long, very passionate comments. And, you know, it was collection right at the beginning of the pandemic. This year, it was in terms of length, they were a little longer than is typical in non-pandemic years, but they were certainly not anywhere near as long or necessarily as impassioned as in years past. So the comments tended to be shorter and less substantive. I have, you know, a few quotes that I've thrown up here. There's going to be a more, you know, more detailed analyses coming, but you know, one thing I think is, you know, we had talked about last year that was interesting was, is this survey kind of an outlet as as a coping mechanism for people who don't have other sources of which to kind of turn? And so what I'm hoping that it means with the qualitative comments is that, you know, people have found other kinds of sources of that coping a year later. Also, you know, we didn't get nearly as many comments about police brutality, calls for decriminalization, but we still did get, though, you know, those did tend to be, we didn't get as many, but they did tend to be, when people had a comment, they tended to be along the same kinds of topics. And so things I think that are related to the community survey, like call for more treatment options, frustration over you know, numerous DUIs that they're seeing in their communities, but then also things that are more adjacent, like we are still getting compassionate calls to help the homeless, for, you know, and the unhoused, for example. We certainly got a lot of calls for substance use treatment and the need for that, and particularly linked to where people were, you know, with COVID-19. In fact, substance misuse treatment was the only topic that was mentioned more frequently than COVID-19 among the respondents to that free space. Anyway, more soon, but wanted to give you kind of a taste of you know, what's on people's minds after they complete the survey. Next slide, please.
So this is our final slide, and I'm just going to note a couple things, really. I'm not going to go through these points that are up here. These are just some of the things that we pulled out as some things we see as we look through the information. But I will note that, piggybacking on what Ashley mentioned, is to remind people that we do two reports, really, that look at the statewide information. The first is the one that comes out sooner, and that's what you have in your hands. That was sent out and distributed yesterday, that follows the format that you all use as communities to report on your data locally. It follows that format, and this gets the statewide information out, statewide estimates out to you that are similar, in a similar way to what the reports that you create. The other is a more detailed report that we do, and that includes the more in-depth analysis work with the qualitative analysis that Ashley was just talking about, but it also includes, and this just gets at that earlier question, it does include some inferential tests and analyses. It may not include exactly what the question was about or what might have in mind, but it does do inferential analyses like that. And that comes out later in the year. So I'll just remind people of that. These are some of the broad trends we see. To me, one thing to really point out is that it's not just in the items we've highlighted today, but across multiple items that ask about community support for addressing prevention issues, there's significant support there. And that's something you all can use. And we we very much advocate you're using when talking with your leaders in your communities about emphasizing that that the community support is there. The survey information shows that for more to be done with prevention. And I guess along those lines, I'll just acknowledge we are in a pandemic that is a very difficult period. Some of these data and trends are not what we'd like to see. Some are really troubling that we've talked about. I think with that, it's really important to understand that this work that's being done, what you do in your communities, this prevention work, is exactly what is most needed right now, and has been, and it's a lot of the reason that numbers and some of these trends don't look worse than they do. It's what was talked about earlier. You're doing that upstream work that helps communities be more resilient in these difficult times. And so I just want to say a thank you to all of you for what you do, and note that. And really, it's where the hope lies to me, because a lot of the news right now is not great, but there's a lot of hope in all the effort that the prevention community puts in, and what it does to help support communities. So thank you. But I think we may be just sliding in right at the time point. I don't know if there are one or two things that are worth noting from the chat, or whether we should just slide right on.
No, I'm gonna stop right there. Thank you, Dave. Thank you, Liz, Marisa, Ashley, the entire PIRE team. Before we break for lunch, please note that you can stay logged into the webinar. Just mute yourselves, pause your camera, but I don't think you need to do that because you're not on camera. But presenters, panelists, you will have to do that. And just step away from lunch, and we will reconvene at 1 p.m. sharp. I will see you then. Thank you so much.